Then
Ma'am. Hello, Sadhana ma'am.
Hello.
Preeti.
Oh,
Hello,
yes,
madam.
yes.
We are live now.
I think
I am sharing the screen now. We are live right now.
Okay.
Is my screen visible?
Yes.
Good evening, esteemed faculty members. We are at Corona privileged to conduct this webinar on e-classic of clinicians for cesarean workshop in association with the Obs and Gyne Society of Punjab, Northern India, and Patiala. We are cordially inviting you in COR CONNECT Live Webinar program. Now I am introducing Dr. Amrita Jaipuria.
It's okay, Piyush. Let's move ahead.
Okay.
Okay.
So I am handing over the session to you, madam.
Thank you. A very good evening and a hearty welcome to our revered guests, Dr. Sharda Jain and Dr. Sushma Chawla, our learned faculty, the chairpersons, experts, speakers, and the panelists, and all the bright attendees who are here to quench their thirst for knowledge. This online workshop is on cesarean section. This is the part of the series of e-classic for clinicians run by Dr. Sadhana Gupta ma'am. And today's episode is also the joint effort of Obs and Gyne Societies of Punjab, the Northern India Society, and Patiala. We all know that the rate of cesarean section is rising. We obstetricians are blamed and are asked to lower down the section rates. This leaves us bewildered. The higher age of marriages, having the first child at the higher age, more complications related to age and other problems, more IVF pregnancies, litigations, lifestyles. All this confuses us. Early detection of fetal hypoxia, IUGR, by ultrasound and color Doppler. They push us to the decision of doing cesarean sections. Well, today I might appear audacious in asking, are we really wrong in doing more and more cesarean sections? Should we actually push ourselves and our patients to the fullest for a vaginal delivery? Or should we evolve our techniques, improve ourselves so that the scar is good, something to be done so that the uterine scar, so that there are less chances of scar pregnancies or placenta previa? I think we should ponder over this and work on better techniques rather than being retrograde. So let us hear from the stalwarts and the experts in their fields, and also the very respected guests who have witnessed the shifts of the trend. At the outset, I would love to call our beloved senior guide, most learned and righteous, our own Dr. Sadhana Gupta ma'am, for her welcome address. Over to you, ma'am.
Thank you, Amrita, and a very warm welcome to all, especially the office bearer of North India and Patiala Society, Dr. Sarita Agrawal and Dr. Sadhana Gupta, President and Secretary of Patiala, and President Dr. S.C. Saha and Secretary Dr. Meenakshi Rohila from Northern India. So because it is all your effort and cooperation that we are always together for learning and sharing and disseminating knowledge and skill. A word about this E-Classic for clinician, which we have started around 1 year ago. And why this classic for clinician? Because medicine is something eternal, like the Indian classical music or whatever is classical music, classical art. And as a clinician, we have to retain that basics of medicine amalgamated with all the advancement. Because today the people are confused with a lot of Western evidence, a lot of complexity, a lot of high-tech issues, which are actually on a earthy level are not available to majority of clinician and majority of the patients. So this classic for clinician, and it is an honor to have all of you at this platform. And it is a great honor to have Dr. Sharda Jain and Dr. Sushma Chawla as a guest, as a revered guest, who have seen like a change of time over the years, that how in the backdrop of the society, with the women empowerment, with the people's expectation, political will, how the obstetrics has been changing day by day and year by year. So hearty thanks to Dr. Sharda Jain and Dr. Sushma Chawla for gracing the occasion. And it is a great pleasure. They are so close that we can have only heart-to-heart introduction. Dr. Sharda Jain is like a true leader who never, like what we say, even in her surgeries, in her ill health, she is thinking of the fellow OB-GYN day and night. We have not seen on a single day that when we have not receiving Dr. Sharda Jain's message or input or suggestion, how the things can be changed. So Piyush, can I have a formal CV of Dr. Sharda Jain? So she is Secretary General of
Dr. Sangeeta, we don't require any introduction. I will ask my senior colleague, Dr. Chawla, to start the things, and then I will follow her. Dr. Chawla has been my senior at PGI Chandigarh.
So, yes. So, Amrita, please share the screen. So, first, Dr. Sushma Chawla, what you see her in a like a red, like what is a scarf, and Dr. Sushma Chawla is one of the person who has like a growing with the grace, like a classical artist who grows with the years. And you can see, beside having this very, very prestigious and very impressive CV, she is a very, very graceful dancer and singer. She is gynecologist, obstetrician, laparoscopic, endoscopic surgeon, already professor ICMCH, and the director of Chawla Nursing Home and Maternity Hospital. She has been awarded.
Dr. Doctor, what you don't know, I will tell you.
Ma'am, we don't know.
Dr. Chawla had been the gold medalist of PGI Chandigarh, all-rounder.
NCC cadet also, ma'am.
Whether studies, whether sports, whether any activity, she was all-rounder. So over to you, Dr. Chawla.
So, and she is active in to help society in lifestyle modification by yoga. So, Dr. Sushma Chawla, again, gratitude for being with us, and please share your views and opinion about the subject and about all the things which is happening in obstetrics.
First of all, I must thank Dr. Sadhana Gupta, Dr. Sharda Jain, and our societies of OB-GYN Punjab for inviting me. But I think you're all so great and all big surgeons, but you are very right that the cesarean section rate has really gone up. And WHO, whatever it was initially and what it was in 2015, they were concerned about why we are doing it. And even the government is intervening. I heard that they will be going to hospital to find out what were the indications. So our documentation should be very good and our indication should be very good. And at least 2 doctors must decide the real indication for cesarean section. But the difficulty these days, the patient should come कि हमने तो पंडित जी से time निकलवा लिया है, हमको तो इसी time ही baby चाहिए. So our whole knowledge of going around all this 50-60 years of study goes all flat when the patient and the relation, they just say कि look here, हमने तो ये करवाना ही करवाना है, we don't want to wait on. So I think this is a dilemma, but definitely we have to prevent the first cesarean section, no doubt. so that next time we are not having the complication of, having a placenta previa, placenta increta, accreta, and the difficulty PPH. PPH is a real morbid things, and ectopics, scar, pregnancy. So we have to really think about it. So indications, and today's webinar is very, very important, and we have to really go into the details why we are doing cesarean section, and of course to prevent the maternal mortality and child morbidity. It is indicated, no doubt. It is boon for the patient who really need it. I wish you all the best for this webinar. I think we are all learned people. You, the youngsters, are much more important these days to decide these things. But I think a group practice will definitely make a difference in deciding, and for the patient satisfaction also. That more people are looking after me. The group practice is very important in deciding even the cesarean section. Thank you very much for the invite, and I wish you all the best. I hope we'll be able to reduce the number of cesarean section, and whatever they say in private mein to ho hi jata hai cesarean. So I've started teaching my patients what are the indications right in the antenatal periods. They count the fetal heart sound. They sit by the side of the patient. The husband stands by the side of the patient to count the fetal heart and the uterine contraction. So they make a party so that they really decide along with us the indication for the cesarean. Thank you very much for the invite. All the best to you.
Thank you, Dr. Sushma Chawla, for your wonderful input and what is the futuristic way that is a group practice, like deciding indication, and again our dilemma what to do on the cesarean section on request. So it is great to listen, Dr. Sushma, and now we are eager to listen Dr. Sharda Jain, who is always like thinking out of the box, and let's listen from Dr. Sharda Jain about the subject.
I think myself and Dr. Sushma are considered oldies, but we have seen last 50 years what the medical profession has changed. I joined PGI Chandigarh in 1970. At that time, the cesarean section rate was 5%. And today, the latest Government of India figures it that it stands around 21 to 22%. Around 15% it is there in the government sector, while in the private sector it is close to 50%. And Madam very rightly said that the government has become very serious that they should keep it to the WHO standards. And what does the WHO says? That it should be kept around 10 to 15%. At the same time, maternal mortality and the perinatal mortality should not increase. Now, what I have seen in the last, I've seen best of both worlds, both of the government sector as well as of the private sector. And I will definitely say that we all face the dilemma of dystocia, which we do not have the right answer. The inductions have become little less these days. And then also there is an entity called fail induction. But I feel that this decreased skill of operative delivery is also gone down tremendously, and increased litigation. Everybody wants the mother to be all right and the baby to be all right in case if anything goes wrong in a private sector. There are litigations plus litigations plus litigations. Now, I'm sure the experts are going to deliberate on every aspect of it. But what I have seen the change has been now the prophylactic single dose of antibiotic now, which is the practice by and large. I see that not only in the private sector, in the government sector also, there are medical colleges after medical colleges in Delhi where only single dose of antibiotic is used, which is, I think, is a great practice. All said and done, I was never in favor of Tolac from the beginning, but once many ruptures and things like that, complications had occurred, the morbidity and mortality of the baby had increased, and every baby cost 1 crore of rupees as far the litigation part is concerned. Slowly and slowly, this has also come down. So these are the two things which we have seen as for the surgical aspect is concerned. Like Dr. Amrita, I also question. I've seen 50 years and I see now my मेरे हाथ से जो बच्चे पैदा हुए वो खुद delivery के लिए आ रहे हैं. That's a change kind of we have seen. And I've not seen, that placenta accreta and things like that happening in cases operated by us. So I think I blame directly to the technique and the technique and the technique. We have to take care of the aseptic precautions. As far as the incision is concerned, now people from vertical have switched rightly to the transverse incision. And as far as the uterine incision is concerned, I think I've been trained from at PGI Chandigarh from Professor P.K. Devi. She used to say that, you must make a superficial incision as far as incision is concerned, and thereafter blunt uterine extension has to be made as to decrease the blood loss during the time of cesarean section. From the very beginning, we have been taught to take out the uterus from the abdominal cavity, and by this the blood loss has been decreased to 50%. When I say it, now it is there in Williams' book, but earlier it was not there, and when I came down to Lady Hardinge Medical College after spending my time at PGI Chandigarh, I was asked to be, आप तो peculiar हो, आप तो uterus ही निकाल लेते हो बाहर। भैया मैंने कहा मेरे बॉस ने सिखाया कि इससे ब्लीडिंग कम होती है और मेरा एक्सपीरियंस भी यही है कि इससे ब्लीडिंग कम होती है तो मैं तो इसको निकालूंगी। And these are the 2-3 things which I see, and I feel whenever the fat is more than 2 centimeters, I definitely feel that some stitches should be put there as to close up the gap. And people now, like any other people like us, also use subcuticular. I would like to have opinion of other people. What do they feel about the subcuticular? The big dilemma has been there in my mind, why placenta accreta happens. I have no answer. My answer is only thing that these are the people who are left unattended by the seniors, and jo unki marzi aata wo karte. That is the reason of placenta accreta. सुषमा चावला से पूछे, मुझसे पूछे, मेरी कुलीग से पूछे, हमारे हाथों से प्लेसेंटा एक्रीटा नहीं होता. So I think I will be benefited what you say as far as the cesarean section things are concerned. And lastly, I will say that in cesarean section, antenatal exercises make a lot of difference. The people who say, हमारे पास time नहीं है, हमारे पास time नहीं है, तो cesarean section rate तो आपकी बढ़े. So this is what I feel about it. I can say all about it. I think all practices are same, that delayed cord clamping and things like that, which is now is a universal practice. I don't have to repeat. Endometritis is very common, and this can be decreased to a large extent if you allow the placenta to separate by itself. And now because of the delayed cord clamping, it has become really the great. जब हमारे को अपने आप बात समझ नहीं आती तो हमें कोई डंडे के जोर से सिखाई जाती है तो बात समझ आ जाती है. Because of the delayed cord clamping, we allow the placenta to separate on its own, and this has decreased post cesarean endometritis to a very big extent. I'm very fond of doing a pre-operative vaginal care also, in spite of that it is an elective cesarean section. So with these words, I think I'm looking forward to hear more and more from the experts. I can see many stalwarts are here from Punjab to deliberate on it. So thank you very much. Before I close, my request with folded hands that Dr. Sadhana is in front of you. Just look at her face. Just look at everything. She's our face, and she's the candidate for FOGSI election this time. So please do not forget about it. There are many people who who are bent upon dividing North India Gynecologist Forum, and we should try to register. So I think Punjab is going to cooperate in a big way, and I'm sure with the Sushma Chawla around, things of that kind will not happen. Thank you very much.
Thank you, madam. I think you have summarized what we are going to discuss in next 1 to 2 hours, and I'm blessed to have your wishes and your words for my FOGSI presidential candidature. And at this moment, I seek everybody's support, guidance, good wishes for my FOGSI presidential candidature. So thank you very much, Dr. Sushma Chawla. Thank you very much, Dr. Sharda Jain. And it is a real honor to have you here. So Amrita, you can.
Thank you.
Thank you. Thank you, Sadhana ma'am. Wishing you all the best. Thank you, Sharda ma'am, for being a big support. And thank you, Sushma Chawla ma'am, for everything, for being here. So let's move on quickly to the scientific session, and I hand over the platform to Dr. Ritu Srivastava. Over to you, Ritu.
Thank you very much, ma'am. Good evening. Let us now begin with the scientific session. And the first session is indication of cesarean section with a special reference to Robson's criteria. And speaker is Dr. Meenakshi Rohilla. To grace the occasion, our chairpersons are Dr. Sarita Agarwal, madam. Please, can I have her CV? Mr. Piyush, can I have her CV? Yeah. She is consultant gynecologist at Agarwal Maternity Center, and she is president of Patiala Obs Gyne Society and vice president of Fetal Medicine Patiala chapter. Then Dr. Dilpreet Sandhu. She is professor Obs Gyne GMCH Chandigarh. She is editor newsletter, ex-member of Sexual Committee Medicine, has held many important posts and has won many awards. Now I request Dr. Dilpreet Sandhu to please introduce our speaker, Dr. Meenakshi Rohilla.
Good evening, respected seniors, and thanks, Dr. Sadhana ma'am, for having me here. Now it's my proud privilege to introduce Dr. Meenakshi Rohilla. Madam is professor in PGI Chandigarh. She has more than 22 years of experience in this field. She is secretary Obs Gyne Society of North India, joint secretary North Zone Yuva FOGSI, editor to a book, and she has introduced a new device, Surveying Pro. So as we are discussing in today's CME regarding our concern about rising rate of cesarean section, let's listen to Dr. Meenakshi, how this Robson's criteria, how is it helpful in reducing this incidence. We welcome you, Dr. Meenakshi.
Thank you. Thank you, Dr. Dilpreet. Is my screen visible too?
Yes, ma'am. Please continue.
Thank you. Am I audible as well?
Yeah, very clear.
Good afternoon,
Yes.
everyone. I would like to thank Dr. Sadhana madam and Dr. Amrita, Dr. Ritu for involving me and the whole organizing team for involving me into this meeting. And with this, I'm really thankful to the Gorakhpur Society. This is for the first time that we have done something with the Gorakhpur Society. And that's a pleasant feeling to involve with all of you. I'm basically from UP and I always have a special feel to attach with anybody from the UP side. So I'm a graduate from Lucknow Medical College and postgraduate also. So I have a special feeling for everyone from the UP side. So with this, thanks, and we will going to be discuss this indications of cesarean section. I would say this is yet a very commonly discussed topic, yet it is a very important and relevant topic, as Dr. Sharda and Dr. Shushma both has said. This is one of the most commonly done surgery in our subject. So it is, yet important to discuss at many of the times, it's not less. So I think everybody will agree with me that high cesarean rates are an international public health concern. So to discuss the classification is just, we are going towards that only, that how can we reduce the cesarean section rate? Can this, discussing some important classification system, can this help us to categorize and can to have an insight into that, and can we have something to do, to decrease the cesarean section rate in our setup? Even the WHO and all international bodies has said with the evidence that cesarean section rate in all low risk population, if it is going beyond the 15% rate, it is not going to be.
Dr. Meenakshi, excuse me, apna full screen कर दीजिए इसको, and it was not moving. I think you were moving a screen,
madam,
so make it full screen. Make it full screen.
Madam Ruchi here. The problem is that she has an old version, and it cannot be a full screen. You have to do like this only.
No, but you can move now. Meenakshi, you are moving slide. Please move it.
Please
it was not moving
move out
also.
from the first move out from the slideshow.
Okay.
And then now it is.
Yes.
Going.
Shall I not make it a slideshow, you mean?
No, because you have a older version of Windows, it is not compatible with Zoom.
Okay, so you mean to say I should not make it a slideshow? That's what?
Yeah.
Okay, fine. I will present it like that.
Likewise.
Can you see my slide moving now?
Yeah.
Yes.
Okay, fine. So we were discussing about the rate of cesarean section. So we need to always, need to see that we are not doing cesarean section rate at the cost of, increasing maternal neonatal morbidity or mortality. So we need to see that. So if we see the Indian data, it is, if we see from NFHS 4 to 5, we can definitely see that there is a definitely increase in the cesarean section rate, even in the low risk population also. And this is including low as well as the high risk population. So with this all data in mind, it was all, consensus was made by all international bodies that it is important to analyze and audit the cesarean section rate in different countries, including primary versus repeat section, and has to, we have to have a special, potential reason why we have a high rate of this, and we have to have an insight into the solution for this. And the very important, the concern was raised that we need to reduce the primary cesarean section rate. So with this idea in the mind, the WHO proposed a classification system to be included in the audit system, and that was given by Robson in 2001, and that was that was proposed by WHO. That is one of the good classification where the all women can be categorized in one of the 10 groups, and it is a very comprehensive classification. So it should be taken as a global standard for assessing, monitoring and comparing the cesarean section rate both within healthcare facilities and between the different healthcare facilities also. So with this idea in the mind, this was actually the Robson who created this in 2001. As I said, it's a 10 group classification system, and it's a global, it was supposed to be taken as a global standard for assessing and monitoring, and it has to be said as a mutually exclusive in all the groups, and it is very comprehensive. So whenever see our size of each group, and we can definitely have an idea about the cesarean section rate within each group immediately, and can give us a significant information about the type of the care we are providing, because it is categorizing all the patient in one of the either of the group actually. So what is this classification is about? It is depending upon the, what is the parity of the woman, has she had any previous cesarean section, what is the number of the fetuses, has she come into the labor, what is her gestational age, and what is the fetal presentation. So this is a picture about that classification. This looks slightly clumsy slide, but if you see one by one, it is not so difficult to understand, and we can make it very clear with a picture also. So I will start with the group 1. It is a woman who has come as a nulliparous woman with single cephalic pregnancy at term and in spontaneous labor. So this is one of the group we commonly receive in all the facilities, not in the tertiary only. In all the facilities we get a uncomplicated term pregnancy with the cephalic presentation in spontaneous labor. So this is one of the group. The second group is the same group of the woman who has been induced or has delivered before the labor by cesarean section. So that's the difference between 1 and 2 group. The third group is a multiparous woman, same term woman with a singleton pregnancy who has come in the spontaneous labor. So this is multiple pregnancy, multiparous woman. So the fourth woman is same as the third group of women, but who has been induced or has been delivered by cesarean section before the labor. So 3 and 4 are the multiparous women, and 1 and 2 are the nulliparous women, and all are with the cephalic presentation in this first column. So fifth group is the women who are all multiparous women who had a cesarean section prior, and they are with a singleton pregnancy and at the term. So this C multiparous woman, the woman is with a one more child in the picture. So it is not too, it is easy to understand. Now coming to the second column. In the second column, the group 6 starts with the nulliparous woman with a single breech pregnancy. Now this column starts with the different presentation than a cephalic presentation. We can say it's starting with the breech presentation, term breech presentation. She may or may not be in a labor, but she has been said as a breech pregnancy. It is I would say it is a drawback here that there's no column that says that the breech is in labor or breech is not in labor. That is also one other thing to be considered actually. The group 7, I will say it is a multiparous woman with a single breech pregnancy and who is with a previous uterine scar. Here the C has not been included in this picture, maybe because that breech itself may not affect the with or without previous cesarean scar. So 8th group is with all multiple pregnancy with or without uterine previous scar. And if we come to the 9th group, this is with the transverse or oblique lie with the singleton pregnancy, and this is all including with the previous uterine scar. And when we are coming to the group 10, it is a absolutely different group that is including all preterm pregnancies and all women with a single cephalic pregnancy who are coming at less than 37 weeks of gestation, and including all women with previous scar also. So any woman who is coming preterm will be included in this group. So this is all about this. When we have this, denotation of this Wi-Fi mark, this denotes a spontaneous labor. So this is all about this classification. It's a 10, it is also said as a 10 group classification system also. So actually what is the utility of this classification? Is this, how does it going to help us? So it will identify and analyze the group of women which contribute most and least to overall cesarean section rate when we categorize our women, all women who had cesarean section according to the group, and when we analyze, we will able to see that what contribute most and what contribute less to the cesarean section rate. And once we do that, we can compare the practices in these group of women with other units also, with other hospital also, and with their desirable result also. How can we actually improve? And once we assess the effectiveness of these strategies and intervention, we can also compare that whether they are actually useful what strategies we have used, and are they really effective in this classification. So with time we can see that also. That's all utility of this classification. And once we see this, we collect the data, we can raise the staff awareness and about this importance of this data and what is the interpretation and use of this classification. So this is the actually utility of this classification. So coming to the next point, this is basically a report table that was given by Robson only, that this should be the table that should be used by all the facilities to give their cesarean section audit. And this table includes all the, what is the group size of that particular group and what is the cesarean section rate in that group. So we also have by Government of India, the table has also been made, and we are supposed to send our cesarean section audit in that table. I will come later to that point. So ultimate aim of this classification over time will help each individual hospital or a setting to identify the cesarean section and that is associated with the best outcome in each of the 10 group. So that is our aim too of this classification. So now the next question comes that what should be the ideal cesarean section rate in each of the group? Whenever we compare with any facility or anything, we need to know what is the ideal thing in each of the group. So with this, I will just explain one of the study and one of the, survey by the WHO that has been given in the Robson manual only, by WHO manual only. Basically, a multi-country survey was done by WHO and it was implemented in more than 300 health facilities in 29 countries and included more than 3 lakhs of the women from Africa, Asia, and Latin America. So by using this survey, a reference population was created, and this consisted of all the facilities with a low cesarean rate yet a low intrapartum perinatal mortality also. So by this survey, the WHO created a reference population, and they see they notice that what is their cesarean section rate and what is their perinatal mortality, and they finally included 42,000 something women from 66 health facilities in 22 countries, and they notice all the things going on in their setup, and then they make some reference point for this each group of the cesarean section rate. So for example, I will put a table here where this is Robson has given some recommendation. I would not say a recommendation. They have given some guidelines that what should be the rate by the reference population. So if you see the group 1, it says that they have seen in their population that if they keep the cesarean section rate less than 10%, their perinatal mortality rate also remains at the reasonable rate. So they have considered that the rate should, we should try to keep this rate around the 10%. And if you see this 10%, if you see the group 2, it was seen that because this is the woman who has been induced and who has the cesarean has been done before she comes into the labor. So this is one of the group there where it was considered that the cesarean section may rise up to the tune of the 40%, though the maximum facilities were having 20 to 35% of the cesarean section rate. Because we do not know the indication of induction of labor, the rate of the cesarean section may vary from 20 to 35 also. This is another example of that table about the group 3 and group 4 also. Group 3, as we have discussed, the group 3 and 4 are the multiparous women. One is in spontaneous labor, the other 4 group is who has been induced or who has undergone section before the labor. So in this group of the multiparous in the labor, the cesarean section has it's just the 3% that has been seen in the low risk population. So we should also try to be minimum in that group of the population, because they are likely to deliver if not, definitely not at the cost of the perinatal mortality, increased perinatal mortality. This is another table that also has been put up by the WHO manual, in which different cesarean section rate has been given for group 5, 8 and 10. The 10 is the group where the preterm pregnancies are highest. So the institute or the tertiary care health center where the most of the referral are of preterm pregnancies, definitely they are going to have the highest number of this group of the cesarean section rate. So we need to categorize, we need to individualize according to our healthcare facility, and we need to supervise that how can we reduce the cesarean section rate in each and every group. So I would like to have a focus on this last horizontal box also, that they have given that it is that look at the absolute contribution of group 5 to the overall cesarean section rate. It is, if it is a very high, this may indicate that in previous years the cesarean section rate in group 1 and 2 have been high, and it is worth exploring further. So what was our group 5? Group 5 was any woman with the previous scar. So as has been very importantly highlighted by Dr. Sharda and by Dr. Sushma also, that we need to curb this cesarean section rate in group 1 and 2. And if we can definitely reduce the cesarean section rate in that group, we can definitely reduce the cesarean section rate in group 5. So by giving this table and by giving some reference point from this manual, WHO has given a note also that rate of cesarean section in each of the Robson group refers to an average obtained from over 60 health facilities and low and middle income countries. So we should not take it as a recommendation, but definitely we can make it as a reference point in a low risk population, and we can try to reduce our cesarean section rate anytime for any of the group, and we can follow that. So this is about our, I hope I am able to shift my slides. Hello?
Yes, you are. Your slide is moving.
Yes, so this was the note that was given by WHO. I will show this slide. I don't know whether in slideshow it is very clear, but in not slideshow it may not be very clear. So this is basically a cesarean section audit form that has been created by Government of India, and we all are submitting this report every quarterly to the Government of India. And this is I would suggest that we have a high cesarean section rate because we have a very high number of preterm pregnancies, and we have a very high number of previous 2, previous 3 and we have a very high number of high cesarean, medical surgical disorders also. Women are coming with these disorders in the pregnancy. So we have a high number of indication of labor also. And we have a presentation of these audits in our monthly and 3 monthly stats also. So every time we try to audit our induction of labor also, so that we can do not induce any of the women who is not having any indication to induce the labor, so that we can reduce the number of cesarean section rate. If we see in group, serial number G, the groups with highest number of cesarean section in a monthly stat, it is the group we are having in our institute is 5, 10 and 2. Most of the time it is 5, 10 and 2. So the highest number we are getting with the woman with the previous 3 or 4 cesarean section rate, they are coming with the placenta accreta also. And the number 10, this is with the highest number of preterm deliveries. And the number 2, where the woman has been induced with some indication of some medico-surgical disorders. Like if the woman is with severe IgA, woman is with preeclampsia, women is with eclampsia, women is with some medico-surgical disorders, she had been induced. So the number has been always high with this group in our institute. So to conclude, basically the Robson classification is an effort to minimize the cesarean section rate. Every facility need to classify that what is our cesarean section rate, where should we actually see that where can we actually improve, and what is the group where we having the maximum cesarean section rate in our institute. And for example, we have this group in our institute, and we should recheck the indication post-operatively and reassess its category also. Many times we the indication we are taking up cesarean section, that may be different, but many times after cesarean it changes our indication also. So a proper counseling for the VBAC, if we want to reduce the cesarean section in that particular 5 group also, we can properly check the record of the woman, that what was the detail of her previous cesarean section also, and we can allow the vaginal birth after cesarean section also in certain group of the patient. So that is also one of the way to reduce the cesarean section. And of course, the primary cesarean section rate to reduce is one of the most prime thing that we can do, and that can be easily achievable also for a group 1 and group 3, I mean to say. So my take home message for all this about the cesarean section will be that ideally all perinatal outcomes should be analyzed using a standard perinatal classification system, and we should try to modify clinical practices to optimize cesarean section rate in specific group while ensuring good maternal as well as perinatal outcome. So that's my take about all cesarean section and the indication about the cesarean section. I have specifically included the Refson classification only. If I've included some slides about the other classification also, but specifically as I was said for this only, so I have included mainly the Robson classification. I would like to take all the questions regarding this. Shall I stop sharing?
Thank you very much, Dr. Meenakshi. It was a wonderful talk indeed. And now I request Dr. Sarita Agarwal, ma'am, to give her expert opinion.
Dr. Sarita Agarwal, ma'am, is not here. She's not able to join today.
It can be taken up by anybody, Dr. Dilpreet or anybody?
Yes. Very nice presentation, Dr. Meenakshi. Even in our institute, we see that same categories 10, 5 and followed by 2. Usually these are the most common categories of cesarean section. So one thing you have rightly pointed out, one is counseling for VBAC delivery, VBAC, and another one more important is avoiding unnecessary inductions of labor. Wherever possible, we should allow the women to go into spontaneous labor. They definitely will reduce the rate of primary cesarean sections, then definitely the other 2 categories will also have less cesarean section rate. So we find it very beneficial in the audits and how we can improve ourselves in reducing the cesarean section rate.
Thank you, ma'am. Thank you very much.
I think it's a question from a suggestion. The problem is, I think we have not included the IVF pregnancies in these. With so many IVF centers which are coming up, I think IVF audit should be extra column for IVF pregnancies, because the same thing for a spontaneous conception versus the IVF with the age and other things becomes a different indication. The second thing which I think I would like Dr. Sadhana and Dr. Sharda ma'am, I think it is wonderful to decrease the incidence of cesarean sections, but suppose we are doing a VBAC and there's a rupture of uterus or get induced in IUGR and the intrapartum asphyxia. I think when we are proposing to the government, we should tell them, if we are trying to decrease the incidence of cesarean sections, the intrapartum asphyxia or complications, the doctors should not be held liable for punishment. Because one reason for increasing incidence of cesarean sections in the private sector is IVF and litigations when intrapartum asphyxia and complications are. So I think as a FOGSI forum, we should tell the government that we would be very happy to reduce the incidence of cesarean section from 50 to 15, provided the doctors are given some immunity when complications occur in borderline situations of emergency cesarean sections and intrapartum or neonatal complications.
Thank you very much, Dr. Yash, for this coming up this. So one thing about Robson's was a wonderful presentation by Dr. Meenakshi. Actually, there have been a lot of issues that actually it is not only IVF pregnancy, it is not taking consideration of any fetal issue or the maternal comorbidity. So it is a simple obstetrical thing which Robson's has produced. So like we have something, if not minimized, that at least we have the audit what we are doing. So there has been a lot of paper. Dr. Meenakshi, I think you must also have learned that many countries says that there are many limitations, yet it can be considered quite a good tool to over the time see that what is happening in institution and what is the facility. It also says that what is our infrastructure also. And a second very, very important thing, Dr. Yash, that actually the fear of legality, medical legal issues, if the maternal or the fetal complication occurs, and always it is said by the lawyer that hardly there is any case where the doctor was sued for doing cesarean section, but there are a lot of cases with a lot of the baby having CP or something, and the doctor was sued for his thing. So this is, I think, Dr. Yash, you have taken very, very important thing that as a professional body, we have to keep our doctors' obstetrician concerned also to the government that it is not a one-way responsibility. We must have the immunity from the legal cases, if anything goes. So this is something very important that we can go ahead with the professional bodies and the the head of the teachers and the institution. So thank you very much for this suggestion. Dr. Meenakshi, we will like to have your comment about you have taken it wonderfully, Robson's criteria, but there are certain limitations, and I think you can complete your talk that what are the limitations of Robson's criteria, so that we are not omitting that she is having any medical comorbidity or IVF pregnancy or any high risk factor. So what's your say about it?
Yes, ma'am. I mean, as Dr. Yash has also said, we have different categories for the every pregnancy is a precious pregnancy, but there are certain groups that are still there which has not been included in either of the criteria, either of the group. So as I was earlier also saying, we have, basically if we go into the manual of the WHO, they say that we are just presenting it, we are not recommending it, we are just presenting to have a cesarean section rate so that you can have an idea what is your cesarean section rate. They are not recommending anything, they are just presenting the data that how can you come down, or you can have the with a good prenatal outcome in either of the group. So there are definitely this has been mainly WHO. Whenever the WHO says any recommendation or any guideline, it always talks about the low middle income countries. So when we talk about the other situation also, this is most of the time it is not being included in that. So that's one of the limitation, that's a group is also there where either of the group do not include those women. So that's my take. One is, and the other thing is, as I already discussed, that once we talk about the group, this 6th group, which is about the breech pregnancies, I would say all breech I would not say are for cesarean section. Still, there are certain group of section where they may be for a breech normal vaginal delivery also. If a woman who has come with a very small size, average size breech pregnancy at term with an extended breech in spontaneous labor with no medical morbidity and without any medical complication, that woman can be for a normal delivery, may not be for cesarean section. So this is also one of the group that it is increasing a significant number of the cesarean section rate also. The other thing I would like to highlight that for a previous cesarean section rate, a woman with previous cesarean section, definitely if a woman is with previous 2 or more, or with any other complication like placenta previa or accreta, she will definitely go for a cesarean section. But in a woman who has come with a previous cesarean section rate, who had a cesarean in a previous well-equipped tertiary care center or a secondary care center, with all the details in the record, with no complication anticipated, with a average size baby, with a no complication happened in the previous cesarean, and we have gone through all the records. This is a very important point. It has been written in the guidelines also for the VBAC that whenever you allow a woman for a VBAC, it is very important to see all the records of the previous cesarean. If you do not get the record, then it may be one of the relative contraindication of allowing a VBAC. So most of the time, I would say, even in my center also, we have so much busy OPDs in our setups. So many times we do not go through a detail of the previous cesarean section records. So in that scenario, we miss that, and sometimes we miss a very important thing that was required to allow her for a VBAC, and there may be on the other hand, there may be something that was very important not to allow her for cesarean section. So that's very important to go through the record of the cesarean section so that we can actually allow or do not allow a woman for VBAC. And if we very carefully and judiciously allow a woman for a previous cesarean section rate, in our setup, the VBAC rate is up to the 60% VBAC rate we have. In all the women, although we choose them very carefully, but when we choose them, they deliver up to the tune of the 60% also. So these are one of the few groups where we can actually look into very detail, and we can have insight that how can we actually reduce the cesarean section. And definitely for the primary cesarean section rate, that's one of the column that we all can try to reduce that cesarean section. More of the CTG, more of the, I would say more of the CTG monitoring, less of a manual monitoring. Maybe it is increasing the perinatal, improving the outcome also, but it is still debatable that it is actually improving or it is actually increasing the cesarean section rate only. So these, it has to be taken in a very broad spectrum and very, scenario that how can we reduce the cesarean section rate? Though I would say it's one of the step to start. We have started a good point to start audit at least. We are auditing induction of labor also. So if we are auditing induction of labor, definitely the cesarean section rate will come down. So these are the things where we can actually have some point to reduce the cesarean section. That's my take on this.
Thank you. Thank you. Yes. Yes, Dr. Benitna. Yes.
2-3 comments. I think it was a wonderful presentation, Dr. Meenakshi.
Thank you.
You spoke from heart. So every gynecologist who wants to reduce cesarean section speaks from heart.
Thank you.
So yeah. So you.
Because we have come from the time where we were always told.
हम government sector वाले थोड़ा दिल से बात करते हैं मैम. So कुछ points ऐसे like I had some points to make. First of all is adding counseling, cesarean counseling or a delivery counseling to the curriculum of the postgraduate students. I think you people sitting in the medical colleges can make a change, because counseling is a very important thing. You counsel for a cesarean section, you counsel for it. You counsel for a normal delivery, patient will go for it. So it is the counseling in the curriculum.
Mental ये देखो क्या हो गया है? ये देखो हमारा बंद हो गया ये आना.
Dr. Ritu, mute yourself.
कैसे करें?
Ritu. I have Preeti and the people. Dr. Alka is also smiling. So counseling has to be added in the curriculum, क्योंकि आजकल के undergraduates counseling नहीं करते हैं. We all know it very well. Sorry to say. The second thing is forceps and ventouse deliveries have come down. The expertise that, like now I consider myself with 25 experience, now I consider myself in the oldies now. But Dr. Sharda, the experience तो नहीं है, पर कुछ experience है. But the thing is, I think operative delivery ka expertise has coming down, and our obstetricians are more into cesarean section. Whatever may be the reasons were already there. Maybe they are increasing litigation and whatever. Government setup may be the cesarean sections have gone high. So like we all take it, we take it with a pinch of salt, definitely, but they have gone high in the public sector as well as the private sector. And because I am dealing with the MCH wing of Government of Punjab, so there is a wide gap, which is a wider gap that has reduced the public and the private cesarean section rate. Now I see that the gap is reducing, and the public sector is also doing more of cesarean section. Maybe we are paying the price for what we have done in the past, that we are all dealing with previous cesareans now. So we are paying the price for the things done in past. And for VBAC, if you are really not totally equipped, I am the person not doing it. As far as the condition of the hospitals, the government hospitals in Punjab are concerned. So definitely our aim is to reduce the primary cesarean section rate. And for that, we have a very good program running, that is the Laksh protocol, the Laksh program, labor room quality initiative. We are doing the cesarean section audits. We have started with cesarean section, the audits of the induction of labor, as Dr. Meenakshi very rightly said. And I have also, we have also issued letters, as Dr. Sushma Chawla was saying, cesarean section audit of the private sector. Private sector is also on the cards and will be coming soon, because it is a joint responsibility of all the obstetrician, whether she is in government setup or a private setup, to reduce the cesarean section rate. And I think I have taken a lot of time. Sorry for that.
Thank you, Dr. Vinita, for wonderful inputs actually.
One comment.
Yeah, this is a joint responsibility. Take the onus of the joint responsibility. And rather than government forcing it, I think it should come from your side, that you also start doing cesarean section audits at the end of the month by yourself. Thank you so much. Thank you.
Thank you.
Thank you very much.
To make one comment, Dr. Sadhana.
Yes, yes.
वो कहते हैं कि जब चिंगारी होती है तो उसे बुझाया जा सकता है, पूरी आग लगने के बाद नहीं. Now is the stage when we can talk about it, we can think about it, we can keep on adding interventions, but the stage has come when cutting down the cesarean section rate markedly. I would not say we will not be able to reduce it, but to reduce it markedly would be a next to impossible. See, let's accept it that we have been always quoting the literature from the developed countries, that litigation, fear, this and that. My own daughter-in-law in a developed country was in second stage for 7 hours. I can't even think of a patient in a labor room for 7 hours, including a first and second stage. So things are very, very, it's very good that you've taken up this topic, because at least there has to be a sensitization, there has to be some kind of an, fear. But I think India has reached a stage where there is no role of incentives, this is a role of disincentives now. Why this is happening, and some kind of a disincentive. Otherwise, we have reached a stage of no return. I remember 17% section rate से एक section ऊपर हो जाता था तो सारी फाइलें महीने की खुल जाती थी when I was doing my residency. Of course, auditing was always being done. Now you can't even think of those things. And as far as going for VBAC counseling and all that is concerned, why it is becoming impossible is because the kind of workload, there's so much of workload in teaching institutes, apart from just simple obstetrics. So many things have been added on. Where is the time for pure academics? That is why we keep talking about academics, but to put it into practice has become very, very difficult.
I'd like to add one thing, if there is time.
Yes, please.
Sure. Yes, Preeti, please.
I just want everyone to just think on what was the average baby birth weight 10 years back and today. One. Second, most of the guidelines, they say that if rather than going for a difficult instrument delivery, it is better to go for a cesarean just for the baby and mother both. Third point, I'm all for the vaginal deliveries, absolutely. But these are also the points which policy makers have to understand. Third, if can we expect to lose even a single baby now in the second stage? At this point of time, when you have the type of population we have and all having 1 or 2 children, will they accept that you have there is sudden IUD in the second stage? Will they accept the baby's IQ is less because baby had hypoxia and CTG monitoring was not done and it was not seen? So all these points also policy makers have to consider. The neonatal mortality, morbidity, maternal mortality, 3rd degree tear, they all have come down. So when we feel proud in showing that our statistics have improved in the quality of life for the baby, neonate and the mother, and at the same time, we also have to think why the quality of life has improved. So we cannot put all the, we cannot just choose that when we have to decide no, cesarean rate has to go down, then we point all the bad points of cesarean rate. And we point the fingers to the private and the government and all those things. At this moment, even in the private, they are very learned doctors and they all are products of good institutes. And in fact, I know that most of the private doctors now, if they deliver normally, they do a big marketing of it. So the things have changed. If there is a vaginal delivery, the private doctors, they enjoy it because the finances have come to the same level. Most of the private institutes, they charge the same for the vaginal and for the cesarean. So gone are the days where it was thought that because they do cesarean for the money. That's not there. And that is something we need to take out from our brains. Secondly, we also have to give proper consideration to the reason why cesarean rates are increasing and what is the outcome of increasing the cesarean rate. If our other parameters are increasing, then we have to rethink about the things. This is the only thing I just wanted to put.
Totally agree with you, Dr. Preeti.
Wonderful
Totally
input by
agree.
everybody.
Very nice.
Wonderful inputs. So I think it is an unending discussion, but we have taken very, very important note from Dr. Alka, Dr. Preeti, rightly, because we have to be very open and see it in the realistic term that, and we should be supportive to our doctors. Wherever they are, we should be supportive for our doctors and the people's expectation as well. So thank you very much. It was something. I think
indication of cesarean section, the documentation part is very important. If we are saying it is a fetal distress, then the CTG has to be there. So this is what we are doing in the audit sections. The indications have to be documented properly. It should be a fetal distress only and not the obstetrician distress. So that are the things.
So let's go Ritu for the second session. I think
yes, ma'am. Let's quickly move on to the second talk, which is standardization of cesarean technique to prevent scar defect. And speaker is none other than Dr. Sadhana Gupta, madam. And to chair the session, we have Dr. Alka Sahil, ma'am. She is professor and ex-HOD Department Obs Gyne and Genetics Center, GMCH, Chandigarh. She's a visiting professor to universities in Australia, China, and Japan. She is executive to various professional bodies and is also chairperson of advisory committee of PC-PNDT Act, Chandigarh.
I think
then Dr. Renu Chakravarti.
Everybody knows me in Punjab.
Yes, ma'am. Dr. Renu Chakravarti. She is consultant at Chakravarti Nursing Home, Panchkula. She is president of Panchkula Society and is associated with Health and Family Welfare Department. Yes, ma'am. I request Dr. Renu Chakravarti, ma'am, to please introduce the speaker, Dr. Sadhana Gupta, ma'am.
Thank you. Thank you, the organizers, for inviting me. It is you have already given such a good, Dr. Sadhana Gupta has already been introduced so nicely, and we really wish Dr. Sadhana Gupta a very good luck for this thing. Just a formal, introduction to Dr. Sadhana Gupta. She is president of North India Gyne Society and co-chair of FOGSI NCT. She is vice president of FOGSI since she was vice president in 2016, and she is member of ICOG convening council. And she is awardee of Best ICOG. There are so many other awards in her, credit. And future now, Dr. Sadhana, we will really vouch for you in the future. Dr. Sadhana, her topic is preventing scar pregnancy.
Thank you very much for a kind introduction, and it is a real I'm really gratitude for all your precious wishes, and I thought that I will keep topic not on especially on the cesarean section technique, but what every Dr. Sushma, Dr. Sharda emphasized, that why we are like having the backlash. So we will have a little reorientation and we will come to the same point. So again, thanks to North India and Patiala Society and for being together. And this is about me. That was an old CV Ritu has played. So I am your FOGSI presidential candidate and I seek everybody's blessing. So I was visited so many Punjab societies, Naba, Patiala, Amritsar, Jalandhar, so many, and this was a very, very fruitful journey in the last, this discussion, which gives us so many points so that we can carry forward the best interest of our doctors as well as the patients. So I bring greeting from land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. So that has to be, we have to be very, very peaceful and not distressed. And cesarean section, always a unique journey, bringing life. This is the only surgery which brings life after surgery, done for the physiological function, and it is the most common surgery performed, and always in the backdrop of the women empowerment and the social. So what I wish to state with the last discussion, that actually WHO does not recommend that it is always 15%. It says that every woman who needs cesarean section must have the cesarean section. So there is no need to run after any particular rates. And the FOGSI also says that every woman is we have the expectation of successful and safe vaginal delivery, but always at the same time access to quality cesarean delivery. So why we are concerned, why there is so much of pressure on us, a social media issue, because we are dealing with the repercussion of high cesarean section rate, economic cost, higher maternal mortality. That is it is a higher than vaginal delivery, perinatal morbidity because of iatrogenic prematurity and long-term neonatal health. And what we are really afraid of, having all cesarean scar complication, which can lead to the whole spectrum of placenta accreta spectrum. And we are actually not knowing what are the actual diagnostic modalities and management modalities which are actually working for our patients. So it is not just a cesarean section, it should always remain just cesarean section. So these are the few new data. It is all recent paper in India from South Asia, which says that we have a lot of complication. So I will go a little bit that what are the issues which can make our cesarean scar very strong. So one is the immediate issue, which are the surgical site infection. We must document what are the high risk factor, like she has the prolonged surgical time, obesity, anemia. And when we have the surgical site infection, it is the first scar issue which we can have. We must have a protocol that we have taken a good swab, good antibiotic. If it is needed, that the surgery is needed, that we have to do the surgery, that is the debridement. So this is very, very important that we can have the surgical site infection which finally can lead to the uterine scar weakness and finally can lead to a lot of issues like the secondary postpartum hemorrhage and the placenta perpetua spectrum. So what Dr. Sharda Jain was emphasizing, that is a antibiotic prophylaxis. I will only emphasize one thing, that the timing of antibiotic should be 30 to 60 minutes before skin incision. So over the time, our teaching also changed. Once upon a time, it was after cord clamping. Somehow it was a concept, but when the anesthetic is given, anesthesia regional, at this time the antibiotic should be given. It should not be 1 or 2 hours before, because many cases are lined up, and you can give the like cephalosporin. If ampygenta metrogel is there, it's okay. You can have the one only single shot antibiotic, but if it is a high risk case, you can go for the 4 to 5 days antibiotic. So individualization is the thing. And every time the what is the like a Western world recommendation might not be useful, and individualization and that honor of clinician for having their own clinical decision is the thing which we have to honor. We cannot go away with the universal safety precaution. And not only our cesarean operation theater, but our labor room must have the strict infection control measure, like proper scrubbing, washing, changing slippers, all nursing staff with cap and mask. And this is the thing where we can actually improve the surgical site infection. Postpartum uterine dehiscence can come to you in a dicey way of the secondary postpartum hemorrhage. It can present to you as early as 10 days to 12 weeks after surgery. And when we discuss the refractory PPH and the coming as a secondary postpartum hemorrhage, just I want to give your attention to that when you find some red flag sign like the presence of bladder flap hematoma, large pelvic hematoma, presence of gas within uterine cavity defect which is going to the parametrium, these are the situations that you have to think that it is not only the suction curettage, it is not only the retained product of conception, it can be the scar dehiscence, which can cause the refractory very, very severe postpartum hemorrhage. So it is another form of scar defect which can present you in the immediate post-cesarean period, and how we can like deal with it. I will just dealing with the next few slides. Pseudoaneurysm with the use of color Doppler. Now we are having a lot of diagnosis of pseudoaneurysm, and we have a sometimes wrong diagnosis of pseudoaneurysm also. So that pseudoaneurysm, we must be knowing that how it is diagnosed. So it is a yin-yang flow and it is a turbulent flow. And whenever there is a pseudoaneurysm, you can like, if it is not having any postpartum hemorrhage, any bleeding, it does not require always treatment. But if the patient is having bleeding, then if it is unstable patient, sometimes hysterectomy. If it is a stable patient, then the uterine artery embolization and other conservative measure can help. So coming to the what is our concern, what is the backlash, that is the placenta perpetua spectrum, which can come after the cesarean section as a gift. How we can prevent it, that is the like I will be dealing and emphasizing on it. And among all late complications, the scar niche which we are now identifying, which we were actually missing in an older time, since 5 to 6 years, we are becoming aware of this entity, that is a scar niche. So what is a scar niche? It is a iatrogenic pouch-like defect in the previous cesarean, and you can see it as a triangular hypoechoic or anechoic shadow at the scar site when you do the ultrasound. The other term are isthmocele, uterine dehiscence, and diverticulum. And we have, it has to be like indentation at least 2 millimeters deep into the myometrium. So scar niche, how we can diagnose it is transvaginal sonography. If you do sonohistography, you can identify more. But the scar niche is that problem that when we are doing a regular sonography, we are taking that a majority of patients post-cesarean have the scar niche defect, and more scar niche chances when we have the increasing number of cesarean section. So how, if that, it is the basis of the placenta accreta spectrum, right from cesarean scar pregnancy to the full-fledged scar placenta accreta spectrum. So where we can intervene when we are doing the obstetrical care for the patient, whether we are doing surgery and the doing cesarean, what precaution we have to take. So that is a reorientation of our surgical steps and the technique, and this factor can be surgery related and the patient related. So when it is a normal, you will see just a hypoechoic indentation. But when you see the scar niche, it is a triangular, irregular, exophytic, outward or inward. So what makes the patient susceptible? So what madam was saying, that our patient don't have the placenta accreta, but the people who are having not a good technique, they are having more placenta accreta. So we will be very, very scientific about it. So whenever there are adhesion, it causes the formation with the abdominal wall. It is a counter contracting force, and that results into the poor wound healing. Retroflex uterus is an independent risk for the scar niche, and the patient factor, that is the previous cesarean, GDM, higher BMI, and the longer active labor prior to emergency cesarean section increases the niche formation, and as well as the genetic predisposition. So always we say that we do the good surgery, but few patients really develop keloid, few patients really develop adhesion. So this is very important that we understand. The timing of cesarean section is very, very important aspect, that which patient develop the scar defect. So if we are doing elective cesarean, like not before onset of labor, 37 week, 38 week, which is a common practice now, we can have more scar defect. And if we are doing cesarean section in advanced labor, that is also causing more scar defect. So the ideal time, what we can say, the time to prevent scar defect is you do even elective cesarean at the onset of labor. So at that time, you will have the right place to give the incision. Beside this, the more maternal age, you can have more like chances for the scar defect, more number of cesarean section, more number of induced abortion. And again, a very good paper from China says that when the cesarean section is done in the peripheral hospital, in the rural community hospital, they have higher chance. And it is our all experience. I think what Dr. Sharda Jain says, it is all, because government is pushing the doctors that their cesarean section should be available in CSC village, but if there are no expert doctors, there are no sterilization facility, any person is doing cesarean section and they not might be knowing that what is the standard for the cesarean section. So such sort of honest paper, actually, this is the science that so many, like Dr. Alka, Dr. Preeti, they give, Vinita, give so good input, because the people who are really working, their experience has to be included in our all recommendation, and we should, like a surgeon, we should see where the problems are. So the non-modifiable factors, you cannot change age, you cannot change retroverted uterus, but you can change that the timing of cesarean section should be at the right time. So modifiable, and that another modifiable risk factor is the surgical technique. So what were the teaching even before like 10 years ago, that always exclude decidua during myometrial repair. That has come again. We have to include decidua, and a lot of, we have spent around 10 years that the people were coming, single layer closure is good, single layer closure is good. But now a lot of national as well as the international studies says that the single layer closure can cause more chances of scar defect as well as the silent rupture. Now, how scar niche can present? It may be asymptomatic. It can come to you as a pre-post-menstrual spotting, abnormal uterine bleeding, because in the niche, the menstrual blood is collected and then the uterus is contracting, and slowly this blood is going through the vagina, and it is causing abnormal bleeding, like prolonged bleeding, intermittent spotting, and the chronic pelvic pain. Now, we are so obsessed with endometriosis that any chronic pelvic pain, we take the Dinoges, and GnRH analog. But in the woman with previous cesarean section, I say you be careful in your ultrasound examination that she is having any scar niche, and the mid-cycle, what it can come as a abscess as well when the patient is having secondary infertility, difficult embryo transfer. A very, very important cause for the secondary infertility, bladder dysfunction, as well as the scar abscess. So these scar niche can cause into the all spectrum scar pregnancy, placenta accreta, scar dehiscence, and the uterine rupture. And these are wonderful paper. One is from Rhode, our Dr. Vidushi Kulshesh from AIMS, international papers. And this is the very good, what we say, the people who are working, their voice and their documentation. Indranil Datta, who says that actually in institution we are facing the Patrita, how that we are having a life-threatening hemorrhage. She had taken medical abortion, or the obstetrician is doing the suction evacuation for incomplete or missed abortion, and we are suddenly faced with the life-threatening bleeding. And that's why we should be aware that this entity is there. We should be very particular what is the, how we can differentiate between scar pregnancy and the missed abortion by all sliding sign. And we have to look what is the shape and size of the scar defect and what is the residual myometrium thickness. If it is crossing around 50 to 60% of anterior myometrium, then it is a clear-cut scar niche, and you can have the outward or inward retraction. You can have abnormal vascularity, and our ultrasonologist friend should also be aware of this entity. And when you are in doubt, the sonohistography, which actually show you that what we are dealing with. So indication, all scar niche are not to be managed. It is only symptomatic secondary infertility, abnormal uterine bleeding. And when the infertility is not issue, COC is good, LNG-IUD not good. But if the patient is having regular bleeding, she is having secondary infertility, chronic pelvic pain, then you have to treat either by the resection by hysteroscopic route if it is very low down, otherwise niche repair, hysteroscopic niche repair, or isthmoplasty, and sometimes hysterectomy as well. So we have to individualize which scar niche need to be treated. But today's my talk is that we must be aware of this entity, which can lead to many life-threatening situations. So primary prevention, minimizing primary cesarean section rate, this is the thing, and what there is concern that it is going to actually increase or decrease. But this is our like aim what we can have, and the secondary prevention. So timing of cesarean section. So what Meenakshi was emphasizing, we must have the detail. What was the course of cesarean section? So with all the technique, we must also write that at what time cesarean section was done. It was elective before labor, or it was second stage, or it was at the onset of labor. Because at that time, the level of uterine incision, when it is towards the cervix, very low down, it results into the poor healing because the mucus from cervical gland interfere with myometrial approximation. And if it is too early, then it is very high, and then again it leads to the scar weakness. So this is very important that we understand that what is the time. And a word about the scar, like standardization of surgical technique. So I had a pleasure to meet Atul Guade in Brazil. And when he gave me his copy of one book and I gave me my copy of Safe Motherhood Initiative. And how is, I think everybody should read checklist, We the Mortals and the Complication. It actually intersects how the surgeon's mind all over the world works. How we take the decision. It is something like it is between us, the patient, the bureaucrat, the politician does not understand. It is we as a colleague understand that how the surgeon works in different environment, in different situation, and how the simple measures like standardization and option like following the checklist actually reduces the all surgery related complications. So why we are not having standardized care? Because we have a forest for tree. We have so many papers that everybody is confused. And whenever we do panel, it is always the thing that, no, I do this thing, I do this thing. So there is a need that there must be standardized technique with, of course, flexibility, so that all resident, all young, all senior have a one thing that this is to be done in this way. And these are the few things which we say again, these are the conventional cesarean section technique, the how we go stepwise, nothing to tell to the august audience. But important thing I will say, the double layer non-locking closure of uterus myometrium, including decidua, is considered the best thing which give you the strongest scar. These are the papers which says about the standardized technique for the cesarean. So transverse fan steel or Joel Cohen, bladder flap development, it is still something that few people are saying that omit bladder flap development. Sometimes I say always direct career. So this is something when you have to do, and the uterine incision. So the blunt entry, what Dr. Sharda Jain was saying, omit routine cervical dilatation, omit the manual removal of the placenta, omit intrauterine wiping, and there is no need for the intra-abdominal irrigation, omit visceral peritoneum closure, omit rectus muscle approximation, omit routine glove change, rectus sheath continuous closure with delayed observable suture. Only when the subcutaneous fat is more than 2 centimeters, then you give the any subcutaneous for the fat and the skin, either subcuticular, absorbable, or stable. So these are the few things which the papers are suggesting that these are the usual standardization technique. And what Madam was emphasizing, actually, what we say very with pridely, surgeon, no, I never exteriorize the uterus. But actually, study shows when you exteriorize the uterus, you can have a good contractile, you can massage uterus, you can visualize adnexa, you can see that what is happening, there is any other pathology, and it takes lesser time. So it is nothing in favor or against, but we must know that exteriorization is not something inferior technique. So double layer non-locking, a lot of paper which emphasize, because that gives you the best residual myometrial thickness. So this is one message, a good number of studies just to believe that double layer non-locking suture is important, and all the things which is the basic surgical practice, that not be too tight, too close, you must have a good traction, it should not be a non-perpendicular, and this is important. Always see for the devascularization, not do unnecessary tissue manipulation, what is the basic thing about the all surgeries. So few new technique they have come up there, it has been suggested, and I think the people in institution, or sometimes anyone can say, so it is a modification of this clap technique, that you give not on the Zoll Cohen or the fan steel, but you go along the natural uterine fold, and where you give the incision, you extend as per the baby size and the two, and what I'm just sharing, that how you can say the 2 layer, and they say that it gives you a very good myometrial thickness. And this is again another suggestion, one paper, that you take the loop, so cephalic to caudal, so cephalic to caudal, and when you pull, the both loops are tightened, and they say that this technique might give you the myometrium to myometrium, endometrium to endometrium, very good approximation. So finally, what we are thinking, that we must give a uterus a very good biometrial thickness and approximation, and for this you must have been double layer, non-locking, good suture material, and all the surgical techniques. So finally, surgeon does not believe in talent, but we believe in practice, we believe in hard work, we are the curious egalitarians. So surgeons are the different breed. So cesarean scar defect is new entity. The Monakshi's talk has set the stage that we have to be aware of the cesarean section indication, and we must be aware after cesarean that what type of scar we have given, what is the surgeon signature to that uterus, and we must be aware of this entity, and we can make, like after 3 or 4 months when patient comes to us on the postpartum period, we can have a look at what scar we have done. So thank you very much for the patient listening. So they say the world has become too complex for simple answers. Actually, they are wrong. So it is time that you choose one simple committed person to lead the organization, who have the experience from the long time, and try to do the best for the society, for the FOGSI as well as the fellow being. So thank you very much. I request everybody that you remember to vote. Every person should vote for me. No vote we should lose. And voting will be from 1st August to 10th August. And who have not nominated yet, please set the nomination, president and secretary, in my favor. Thank you very much.
Thank you so much, ma'am. It's really rewarding listening to you. Now I request Dr. Alka Sehgal, ma'am, to please give her expert opinion.
I thought my opinion has been, amply covered by Dr. Sadhana herself. She was given one topic to talk on, and she in that time has covered both the things, not only the techniques of cesarean section, but also the complications, which was actually really required to be covered, especially for the younger generation, because we are going to see more and more of these complications. I just would like to add on one thing, Dr. Sadhana. Somehow, personally, yes, when Dr. Jan was talking, Dr. Sharda was talking about those steps of techniques of cesarean section. Yash, you are smiling. I thought, what was new? I mean, we had always been taught these steps. You know, they came just naturally to us, probably because of, I think, Dr. G.I. Dhall's teaching and everything, because they were MRCOGs, FRCOGs, and those RCOG guidelines came very natural to them. Every step was taught to every student. So they just came naturally to me. When I was going through the meta-analysis, I thought, what was new in it? We always knew it. But the complications are now, coming and getting picked up more often. More because most of the obstetricians have ultrasounds in their own hands now. So two things which I wanted to stress was, one thing, exteriorization of the uterus was plus minus, but what is most important is when you exteriorize the uterus, then there is a possible, when you replace the uterus, there is a possibility that you must check the angles once again, because your uterine arteries were at a stretch, but when you lay them back into the abdominal cavity, there is a possibility that your suture may be loose and the bleeding. So cross check once again, once you have put in the uterus. That was one. And the second, somehow, I don't know when I'll be able to put it in on records, but somehow I'm not fond of cleaning the uterine cavity. We never did it for normal vaginal deliveries. Where is the need in a cesarean section? Probably more important than that is that we must hammer that placenta and complete membranes should be checked. Probably by too much of intrauterine cavity, maybe we are adding on to adenomyosis. I somehow am absolutely not at all in favor of mopping.
That was also in the standard. No need to wipe the uterine cavity. Yes. That was it. No need to wipe it.
Everything is in front of you. If you can't make it, if you can't see it just open in front of you, then what? We in normal vaginal delivery we were never doing it. So. And another thing which I would just like to add is everyone should know ultrasounds themselves. Why should we be dependent on radiologists for a small area? I've been practicing ultrasound since 1990. And believe me, what I see on an ultrasound, I tell them, please look for this in the CT scan and MRI. I have never been able to see anything more than what I have seen in an ultrasound on MRI and CT scan. And I'm proud of that. And that is why people should pick up the probes now. They should have, most of the people have it. And that is the two things which I wanted to. And because Dr. Sadhana has covered two topics when given a time of one, I think we must make sure, all of us should make sure that she gets 2 votes, one for us and one for another one. Thank you, Dr. Sadhana. It was wonderful having you here.
Thank you so much. Comments if I'm allowed. I think we are creating more and we are diagnosing more. So I think the difference which I feel, let's own up. Maybe our teachers taught us better cesareans than we have taught to the next generation.
Yes, I completely agree with you, Yash. I think there was a paper which has been published by me and one of my colleagues. Is it time to segregate obstetrics and gynecology?
Oh no, please. I think that's a bad idea. Please, if we segregate.
No, not that way. Not that way, Dr. Yash. Because what I have seen is even in teaching institutes, now more and more obstetric practices in hands of juniors, and somehow seniors are getting away with learning more of laparoscopy, oncology, and that makes a difference. It has made a difference. I'm a witness to it. the kind of surgery, you know, from where to hold the forceps. We have learnt our surgeries from there. Dr. G.I. Dhal telling us where to hold the forceps. Now,
Second thing is, I think we have Meenakshi Dilpreet Alka.
Ma'am, yes, please speak into the mic. You are not audible as always.
I'm not audible.
Speak into the mic. Yeah.
I'm into the.
I think contrarily, I would say stick to the time rather to the mic because we have a panel now.
We should
Yes.
Exactly.
Should not be covered. I think we should have a double-blind control study. I feel Vicryl somehow is contributing to more scarnosis. So I think maybe in the institutions or even otherwise, we are having thick number 2 needles and nothing happened with the scars. We never saw stenosis. We never saw scar pregnancy. We hardly ever saw ectopic. So I think we should shift from Vicryl to chromic. Let the when the uterus is involuting and the suture is not. I think that is what is causing the problem.
Yes, let us not blame the doctors and the equipments and the other things. I think the current generation, their tissues are also very gentle.
Oh, no, I don't agree with that. I think human body hasn't changed, our mindset changed, and I think we should compare Vicryl with chromic and let's review our thing. I think because Vicryl takes 90 days, the uterus goes back to normal in 6 weeks, and the Vicryl does not dissolve. So my thing is, ever since we started using more Vicryl, we are having scarnage problems. So I think that is one area to be considered in the institute.
My next thesis.
Thank you so much. Thank you. Thank you very much. Now let's quickly move on to the panel discussion. And we are hoping for a very brilliant discussion between the panelists. And our moderator for the panel discussion are none other than my Dr. Sadhana Gupta. She is Director, Senior Consultant, Jeevan Jyoti Hospital Research Center.
It's okay.
And ma'am, I would like to say something just a minute. She is the ablest, most dedicated, hardworking, sincere, and a great academician. And we should all strengthen hands for the presidential candidate for election year 2023. Yes, ma'am. And Dr. Amrita Sarkari, ma'am. Madam is President, Gorakhpur Obs and Gyne Society.
Ritu, let's go on.
Yes, ma'am. Please, I request Dr. Amrita Sarkari to introduce the panelists as well as the experts. Thank you, ma'am.
So we are quickly moving on to the panel discussion, which is on difficult situations in cesarean section. And for this, we have great experts. First expert is Dr. S.C. Saha, who is the Professor, Department of Obs and Gyne, Postgraduate Institute at PGI Chandigarh. And Dr. Saha has many publications to his credit, more than 75. Our second expert is Dr. Preeti Jindal. She is the director of...
Please flash the CV. Please flash the CV. Piyush, Corona, yes.
Yes. Okay, so Dr. Saha and Dr. Preeti Jindal, she is the director of her clinic, and she is IVF specialist, cosmetologist. She is interested in high-risk pregnancy, and she's a laparoscopic and robotic surgery expert. She has many awards and honors to her credit and many publications. She has written books also, and she is the chief editor of Aesthetic and Regenerative Gynecology. Next slide, please. Our panelists are Dr. Ranjana Gupta. She is the director and consultant, Gupta Hospital at Patiala. And she is also the honorary secretary of Patiala Obs and Gyne Society. And her areas of interest are high-risk pregnancy, ultrasonography, and infertility. Next, please. Dr. Ashima Arora. She is associate professor, Obs and Gyne. Her affiliations are Postgraduate Institute of Medical Education and Research, Chandigarh. Her achievements are many. She's a gold medalist, many publications to her credit, and her field of interest is critical care obstetrics and reproductive endocrinology. Dr. Vineet Nagpal is a senior gynecologist with Punjab government, and she is the assistant director, Department of Health and Family Welfare, Punjab. She has an experience of more than 24 years in high-risk obstetrics and gynecology. She's a national trainer of comprehensive abortion care, and she's a straight trainer of SBA, PPIUCD, ARSH, RTI, ANTRA, Lakshya, MDSR, FOGSI, and CAC IYFT. She's a life member of all the societies we know: FOGSI, Menopausal Society, ISSAR, founder president of MOHOGS, and joint secretary Menopausal Society of Chandigarh, ex-executive member of COGS, and she has visited Ethiopia and Gabon as a part of VIT, Medicare Rotary International Health Mission. Welcome, ma'am. Next, please. Dr. Yash Bala is the Director of Obs and Gyne, Cloud9 Hospital, Panchkula. She is the President of Chandigarh Obs and Gyne Society, visiting senior consultant at Jindal Center, Sector 20, past secretary of IMA Chandigarh, and she has an outstanding academic career. She has her post-PG experience at PGI Chandigarh. She is an invited faculty to various conferences and has many publications, national and international, to her credit. Next, please. Welcome, ma'am. Dr. Susmita Sharma is the Professor and Head OBGY, Dr. B.R. Ambedkar Institute of Medical Sciences, Mohali, Punjab. She is a gold medalist, has 30 publications in various national and international journals, and she has authored 2 chapters in textbooks. Her field of interest is high-risk pregnancy, gynae endoscopy, and medical education. Welcome, ma'am. So these are our panelists, and now we move on to the panel discussion. So we welcome our experts and panelists, and let's see what we can come out in this discussion.
So, we have taken a lot good time in the discussion. So difficult situations which we frequently discuss, and few we will take a little bit which are off the line. So we will be finishing, Amrita, me and you, within 30 minutes maximum. So welcome all the panelists and the expert to this panel, and it is what cesarean section. So before Amrita, before we go to the difficult situation, just one comment from Dr. Sadhana Gupta that how for your choice for the anesthesia, because one thing, anesthesia and our battlefield where the cesarean section OT is done. So it also set the stage. So Ranjana, Dr. Ranjana, your comment on your choice of anesthesia for the cesarean section.
It could be spinal or the epidural, as it is a safe. Depends upon the anesthetist choice. Like if the anesthetist is expert, then he can go for spinal anesthesia. But if the epidural, the anesthetist is like feasible giving epidural, then it's better if we give epidural anesthesia. And for some conditions where like spinal or epidural cannot be given, only GA is to be given, then certainly we have to give GA.
So the one message from Dr. Ranjana is that it is a general consensus that it was not that the general anesthesia, actually we must have the indication if we are using general anesthesia, and the regional anesthesia is the better and the safer. It is good for the mother, it is good for the baby, it is good for the obstetrician as well. So rightly said. And the second question to Dr. Ashmina, that what you expect, like we talked a lot about, this was why this all discussion, because Dr. Meena also commented, and everybody, that senior people are not hand holding the juniors, so they are coming out with a quite good range of the technique. So when we are planning a hospital, when we are planning an institution, what the expectation you must have from the cesarean section OT? It is another room, or it has something different from the other OT? Ashmina, and then we will come to the expert, our Preeti, for her comment. So Ashmina, your opinion about it.
Good evening, ma'am. Thanks for having me here. No, ma'am, it is not just another room. A cesarean section is the most commonly performed surgery worldwide and has a lot of implication on maternal morbidity. So it should not be just considered another room as a part of a delivery room. It is an important place. It must have access to the all the important areas of the hospital. Rather, now the government of India has clearly mentioned that the mother and child center should be well equipped with all facilities that may be needed within that place. So definitely the place must have the basic minimum requirement of all the resuscitations that may be required, even in the smallest centers where they may be, as such, they may be feeling that they are maybe operating upon low risk women, but it is not so. Any cesarean section may turn out to be high risk intraoperatively or post-operatively or pre-operatively. Hence, it must be equipped with full resuscitation for both mother and baby. So it should not be considered just another place. Not only the surgical equipment, but also the resuscitation equipment, full crash cart, full resuscitative measures for mother as well as baby should be fully available in the operation theatre. And cesarean section must not be considered as a routine procedure that is being carried on by anyone, and hence we do not need preparation for it. Not so. It must be taken to be a major surgical procedure, because it is one. There is no doubt denying that it is a major surgical procedure.
Thank you, Ashmina. Preeti, you want to add to what, like how when we are like having the architect meeting or something, what we should be very assertive that our cesarean section OT should be like this.
Yes.
Preeti, your comment about it.
Yeah, the one, just briefly 2 lines. I would like to say, one, that every hospital where laboring patients are there, one OT should always be standby, because we never know when we'll have to do a cesarean, and then 2 lives are at risk, and then we cannot wait for 1 hour or 2 hours. This is one major requirement, an obstetrical OT dedicated only to obstetrics. And second, as rightly said by Dr. Ashima, we should not take it lightly. Cesarean section is one of the most bloody surgeries, and we need good anesthetist and all the equipment in that OT, because it can turn from a very simple cesarean to a mother landing up in shock. And we may need laparotomy set and everything over there. So please do not take cesarean section as a routine, very simple surgery.
Thank you very much, Preeti. And
Ma'am, I could also like to add,
yes,
rather not only any OT, one OT dedicated which is attached to the labor room, and
yes,
within the labor room campus should be dedicated to emergency cesarean sections for women in labor. We cannot.
So that's why, yes, very important, because when we are having this Manyata and Lakshya, when the facility is standard, so the OT is on the 2nd floor, labor room is on the 1st floor, and there is no connection. So how the patient is, so it must be very close, a good ramp, or it must be on the same floor. That is very important. Buffer area must be there, and what the cesarean section, the neonatal good workstation. Even sometime I go to some corporate sector, and they have so many things, but they don't have a very good neonatal station. So neonatal good warmer oxygen suction, neonatal resuscitation is that very important, and the temperature maintenance and all the thing that the obstetrics is we must have all intercom and our facility, because we never know that when we want to have a call for help. So choose your battlefield. That is very important. Then our battles will be fine. So this is all what we said. And these are good papers that what are considered a difficult situation. So Amrita, you read out this case. This is a simple day-to-day case, but is it difficult or it is easy? So Amrita, over to you. Unmute yourself, Amrita, unmute yourself.
This patient is a 3rd gravida, rural woman having previous 2 cesarean sections. Hello, ma'am. Am I audible?
Yes, yes.
Yeah. 1 living child, 1 vertical incision at rural PHC, child expired after an hour. 2nd transverse incision, Joel Cohen incision. Child is alive and healthy, 3 years old. Has come to us with mild pain off and on. Ultrasound report is 37 weeks gestational age, cephalic presentation, placenta is upper segment, and liquor amount is normal. Hemoglobin is 10 gram%, and other investigations are also within normal limit. On examination, her fundal height is 36 weeks with floating head. Fetal heart sound is good. And she wishes to give, she asks for a date for cesarean section. And she is coming from long way and wants the cesarean section in the facility, especially for loss of the child after the first cesarean section. Is it easy or a difficult situation? And any further questions we would like to ask? And this question is for Dr. Vineet Nagpal and Dr. Yash Bala, ma'am. So how to optimize the pre-cesarean workup? And patient wants to know now, where will the scar be? I mean, she wants to know whether it would be a vertical one or the transverse one. So question to you, ma'am.
I think I have few questions more in this case. One is, what is her blood group and is the blood arranged in the antenatal period?
It is 10 gram, like
10
positive.
grams, she is there.
10 gram, ma'am. I think previous 2 cesarean section, she's a pretty high risk case with the loss of one baby also.
Child,
And
yes.
what is the age of the children? Ma'am, can I get the age of the children?
3 years. The only one child is living. 3 years child.
3 years, and the previous one was what was the intercesarean
Interval
between those 2 cesareans? No, between the first baby and the
Say 2 years. Say 2 years. 5 years. 3 years. Say you can say. You can say 2 years. 2 years. You can say.
Okay, yes. 2 years between those, and the second one was an elective cesarean. The first one was an emergency cesarean, and the second one is elective cesarean. Okay.
Yes.
So that will depend upon the, I think, what kind of setup that I have. Should I come with more questions or should I be answering these?
We want to give the all clear question to the audience that through cesarean we are going to have elective cesarean. So when you want to do cesarean, it is 37, 38, 39, and the second thing, what pre-operative preparation you will say that it is patient में बोलते हैं ना कि अभी कुछ होगा तो नहीं हमारा तीसरा operation है. So what you are in mind? I think you have raised few things that what is blood group arranged, blood arranged. So timing of cesarean section, just I wish to like.
Yes. I think most important thing would be if I have the second cesarean report.
Yes.
Because that will
complete
make
documentation of
the report of the second cesarean section, number one. This patient, I will tell her to stay locally now. I will not let her go back. If she has somebody where she can stay, or I keep her in the hospital, is a different story. Number 3, I will like to do the ultrasound myself, assess the placenta, assess the scar. Okay. So the second cesarean was done in transverse, and the surgeon found no problem intraoperatively. I think in the current scenario, doing just a vertical, because previous 2 are, there's one previous vertical scar is no longer a mandate. If the second cesarean, they managed to do it pretty well, but assessment of the scar and assessment of the placenta, I will be doing myself. We'll be doing it in a center where I have a backup of the ICU available, the pediatrician, because we have a previous neonatal death which has not been assessed as a cause, and 2 units of blood in hand, because hemoglobin 10 may not mean anything. I would like to have her ferritin as to what it is. I'm sure the other parameters have been taken care of. If the second cesarean was done at 38 weeks and there was no scar dehiscence, if it has been mentioned, okay, that there was no thinning of the scar, I would like to go to 38 weeks. But if the previous scar was done at 37 weeks and then the scar was bad at that time also. So the situation of the scar and the gestation of the second cesarean is what is going to make me determine my primary thing, and it is going to be reinforced by my assessment of the placenta, location, the scar, and the placental maturity, besides other factors like AFI and the biophysical profile or movement count. So if all other parameters stay normal, I would like to stretch her to 38 weeks if the second cesarean was done at 38 weeks. And the scar.
Thank you very much. So
what
just,
yes. Ma'am, the placental position is very important with previous 2
It is fundal. It is fundal. No issue about it. It is fundal. We will come to placenta previous situation, but it is fundal. Final, it is fundal.
As Dr. Yash said, we will definitely wait for 38 weeks, but with her in the hospital setup or nearby the hospital when she is just a call away. And secondly, I think I will not go beyond 38 weeks, even 1 day beyond that. I think 37
very nice.
plus 6.
So 36 weeks. I think both panels say that it is around 38 weeks. So 36 weeks. So many times we do early because the patient. So this is important that we avoid The early term maturity. What is the early term prematurity?
Lower segment also at 36 weeks, that might be not very good.
And
so for us,
yes, and Preeti, we will like to have your comment because we will take 4 or 5 cases. You want to excise the previous transverse scar, or you want to make another scar? So, what you want to do, Dr. Yash?
I would like to excise the previous scar and make a fresh one at the scar site. In fact, I excise the skin, but I try to go away from the previous scar in the subcutaneous tissue, so that I avoid the skin incision should be the same, but try to find a slight virgin area between, in fact, if you can get a place between your vertical and the transverse, because the area which really gives you the trouble is the T junction, where the previous transverse touches the vertical. So if you can have that area slightly cleaner, the wound healing would be better.
Yes.
Just two things. Two things. We do a PV and see she is not in labor. She has come with pain off and on. And secondly, about the betamethasone, if she is around just 37 and we have to take her, then we still give at 37 weeks selective cesarean steroid dose. Just 2 months.
I think that is no longer a complete recommendation. I didn't want to touch Betisol, because day before we had a complete panel on antenatal steroids, and after 35 weeks, if you want to give steroids, it has to be a written informed consent that steroids are associated with neurodevelopmental disease. I think the latest recommendation of ICN is no longer to be given beyond 35 weeks unless without a written informed consent of long-term neurological seizure.
Very, very important thing. So now this is excision of previous scar around 38 week and all the like a backup for all the necessary thing. So now coming to the second situation that you are going, so it is all well, but when you are opening parietal peritoneum, you find that uterus is densely adherent. So Dr. Sushmita is with us, na? Dr. Sushmita?
Yes, ma'am.
Yes, Sushmita. So you find a very, very common situation in previous areas that you find no place to go and so your tips and tricks. Please mute the corona people. Please mute except the panel so that. Yes, Sushmita.
And this is a common situation which is probably seen in previous cesarean section. So the aim should be that we should do a sharp dissection, layer by layer.
Corona people, please mute the other except panel, please.
Piyushi, somebody with Samsung 5 is talking continuously. Please see that.
Yes, the thing is that it should be always be a sharp dissection and find a virgin area as high as possible. Definitely, we should be thinking of bowel. And then if you require, you may take a surgeon's help also. Traction and counter traction is also very important, that we need to give a counter traction and we should go high up to find a virgin area from where we can open up the peritoneum. After opening up the peritoneum, the main aim is to identify the bladder peritoneum, and that should be the bladder flap should be made at least 2 centimeters so that the incision line can be defined where to give the incision. And that has to be sharp dissection and adhesiolysis.
I think, Dr. Sushmita, you have covered everything. Go from virgin space, sharp dissection, and be aware that you never go anything blind, because bowel can be adherent and the bladder can be adherent, and that's by opening.
Your scissors should be always be in a way that they are, you are avoiding the injury to the bowel.
I think, can you go to
yes.
the first slide?
Yes.
Avoid use your finger, that's much safer, number 1. And once you are entering, try to enter laterally rather than trying to enter the center. Lift up against the traction, you will be always, and just see where the fat hold is. That's where the bladder is. The fat is wherever the uterus, it's always the bladder.
Thank you very much, Dr. Yash, because that is the lateral entry, because you just find that where is the thin peritoneum and you have to live. So now coming after this, because it is 38 to cesarean section, now you are struggling with the floating head and head is high. So always a question that floating head, how to take. So Dr. Ranjana, your comment about that, how you do the floating head, your very brief thing so that we can cover 4 or 5 cases.
Yeah. In the floating head, first of all, I'll ask my assistant to stabilize the head, that the assistant would hold the head and fix it. And I'll give a very small incision in the uterus so that the liquor has to be drained very slowly so that the head is in place. And then to deliver the head, there are 2 techniques. What we had been taught in our PG days, that the push technique. We still find it useful, the PG technique, the push technique. Here, one of the assistant that he pushes the head from below through the vagina with 4 fingers, not with 1 or 2 fingers.
Ma'am, that is for impacted head, ma'am. Probably they want to
It's a free head, sorry. That's the impacted head. I'll ask my assistant to hold the head, and then slowly it would be drained. And then with when the head is stabilized, and then we can deliver the head. Or we can use forceps, 1 blade as vectors, or both blades can be used, or we can use the ventouse also. Some people are very expert in using the ventouse. So these all modalities are here for the operators to do. But what we have been doing is either forceps or with the hand we can take the baby out.
Thank you, Dr. Rajna, for it, that forceps or you are just fixing and a little bit fundal pressure, because we will like to have the expert comment. Dr. S.C. Saha has joined or not, that vacuum is a right concern that few people, because actually what is in the vaginal delivery as well as cesarean, the young generation is not attuned to forceps. And there are a paper who says too concerned that we are having more neonatal issues with it. And the secondly, the vacuum is meant to, it is a perpendicular direction because it is meant for the vaginal delivery. But for cesarean, we want a tangential thing. So the routine, what is the routine vacuum might not be that good for the cesarean delivery. So this is few points which we want to give, that we need further research to clarify what is the safety of vacuum assistance in cesarean delivery. So any comment, Dr. Saha and Dr.
Blade or forceps as a vector, I think, is the most effective if your hand is actually not getting the head stabilized. I use it.
So very nice. I think I also I think Amrita will also agree that 1 blade of forceps usually do wonders because you can push it in your direction in the instillizing.
I think the literature and the experience, number 1, I think what we are talking about, the fundal pressure in head delivery, with the previous 2 scars, try to avoid that. 1, it tends to fail. 2nd, it tends to extend your incision. Okay, if you are not sure, vacuum is much safer than forceps, because a wrong application of blade of forceps, you can end up in a trouble. Vacuum is much safer and much easier to apply. And so if you are comfortable with ventouse, not with the forceps, in a free floating head, it's not very difficult to deliver as breech. Reach for the leg and deliver the baby as breech when you're not sure about applying ventouse or applying forceps in a free floating. Please do not struggle with the fundal pressure in a free.
So thank you very much, Dr.
What our teachers used to say, अगर बच्चा नहीं आ रहा है तो बच्चे के पैर पकड़ लो.
Thank you very much, because the studies also says that the internal podalic version, yes, internal podalic version, yes.
One thing I like to add.
Yes. So studies also says that sometimes internal podalic version is as quick as, sometimes what you say you take and the head is going up. So there is no way. So Preeti, your comment about it.
Yeah, just again 3 things. What I have realized over time, when you're giving an incision on the uterus, give it little above the head. Don't give it too below, otherwise the baby will slip. Second important thing is your grip. Do not leave your grip. If you leave your hand and come out, it will slip, and then let the liquor float, and then just hook the head out, and you will never have any problem.
Thank you very much, Preeti. You've done this. I think it is all. So these are the all issues, and just a question. Actually, every experience matter, but what is the overall research says? So any caution which we want to communicate to our all audience and the participants. So now, Ashmita, for you are doing this 3rd cesarean section, and suddenly you find Polly's bulb in front of your eyes, or the urine suddenly splashing into. So Ashwina, how we prevent and how we deal with these situations.
So, though ma'am, I would really wish I don't see it, but yes, I have to be prepared. So first most important thing would be to prevent it rather than to see it and then take action. So as we said, we have to be careful while entering the abdomen in previous surgeries to enter as high as possible for peritoneum, enter a virgin peritoneum, do a sharp dissection. These are the ways you can prevent it. If you are still not sure, sometimes you may need to retrograde, fill the bladder, identify its edges, then do a sharp dissection. Your incision must be, your bladder must be dissected away enough to give you space for an adequate uterine incision. And then these are the ways to prevent. Now coming on, if you are already seeing the Foley's, like you said, so there can be two types of injuries to the bladder, as we know. Once in virgin surgeries, most probably you do bladder injuries at the dome while entering the peritoneum. While in previous surgeries, most likely you do bladder injuries while dissecting the bladder down, and that can be at the, that may not be at the dome as such. So if it is a ideal situation would be that you see where is the injury, what is the dimension, what is the doubt that a ureteric orifice could be near it. So that would be the decision of whether you are adequately equipped to repair it yourself or you need help from an expert. If you feel that it is at a place where ureters may be observed, I will take care of this.
Hello. Hello.
Ashima, the voice.
Ashwina, your connection.
I think we lost the connection.
So Preeti or Dr. Yash can take it along. She was very, very correct that we have to see dimension and the location and whether we can do it ourselves or we need to say. So Preeti and Dr. Yash, you can take along with this, that how we deal with when we really have injured the bladder.
Yash ma'am, you can take the question, please.
Yeah, I think if you've done it in the past, I think I'm also muted. Yeah, am I audible?
Yes, you are audible.
Yes, ma'am. Yes, ma'am.
If you've never done it, don't try to attempt it the first time. Call for help a person who has done it. Otherwise, a sharp injury at the time of cesarean, it's not difficult to repair. In fact, put in methylene blue so that you can see the edges and repair it in 2 layers. If you're confident, you don't even need to put that methylene blue. You can repair it on your own. Number 2, chromic, or number 3, 0 or 40 bicrate, either of the 2, whichever is available, is as good. And a primary repair, and earlier we used to be talking about keeping the catheter for up to 3 weeks. These days it's not indicated. A sharp, clean dissection, if you've done it, 5 days of catheterization is enough for a primary healing to take place. And if you have not used the methylene blue before the repair, after the repair, put it and see that your incision line is absolutely free, and then repair it. Suture the visceral peritoneum in this situation if you are not doing it otherwise. So that we have 2 layers of the bladder, and the third gives you additional layer, but check for this thing by putting methylene blue after the repair to see that you are it's a leak proof and you're not kept any area. Putting in a ureteric stent is not difficult actually if you are it's under vision. So you have seen the bladder injury, but when you're struggling with adhesion, sometimes you've done a ureteric injury which goes undetected, and that can end up in a trouble. If your bladder is open, just take in this thing and try to do the stenting of the ureters so that you check for the ureters along with. Because bladder injuries are easy to see, ureteric injuries generally go undiagnosed and they are more painful in long term than the bladder injuries are. And
thank you.
2 important points. 2 points, ma'am.
Did I lose the connection or was it lost from?
You lost connection.
Okay, sorry. I thought the meeting had ended and I had to log in again. Sorry.
So 2 points I just want to add. One is that, first of all, do not panic. Complications can happen and they can be sorted. Second, I would definitely prefer if a urologist is around, I would, because it can lead to medical legal complications. But of course, we all can stitch it. But if a urologist is available in your facility, always wise to call the urologist.
So thank you very much. Ashwina, we lost something. Madam says yes. What you are taking, Dr. Yash take from that side, that location and the size, though the bladder is a forgiving organ, and if it is extraforaminal non-dependent, we can clearly suture quite well and quite confidently. And madam says that it is 5 days catheterization, not 14 days. So your comment about post-operative, because out of our utter carefulness, we don't want anything to happen. So the people take the catheter for like 10 days or sometime 14 days. So your comment about that 5 days is enough, or it is 10 to 14 days if we have injured the bladder and we have sutured post-operative.
No, ma'am. Even the guidelines say keeping the catheter for 5. Ma'am,
a little bit voice is breaking.
Still not
voice is breaking.
Hello, ma'am. Keeping
yes. Ashima, just try
off the bladder, keeping the catheter for 5 to 7 days is adequate.
5 to 7 days is what is recommended.
7 days is okay. So 7 days is okay. Now coming to the opposite of that situation, that is the cesarean section in second stage of labor. So what it is a deeply impacted head. So from floating to deeply impacted head, your quick comment about, because it is often discussed, Dr. Vineet Nakmal, how you tackle with the cesarean section in second stage with deeply impacted head. And we will open this. So Vineet, how your comment?
I think, ma'am, we have discussed most of it. First of all is call for help. Don't start this cesarean by yourself. Even if you are in a public sector and very expert, please call for help. There is no this thing in calling for help. We should always call. And 2 persons are always better than 1 in dealing with such type of cases. And the proper consent is very important in such type of cases.
We will go only for the cesarean technique, which is done. So while you are just operating, so if agar second stage mein kar rahe, so how it is a little bit different from the standard approach.
If it is a second stage, we have to really look for because bladder will be high up. So our incision will be according to that. Because bladder will be high up, it will be distended. So we have to be very careful that how we go for our uterine incision. And
so rightly lower the head, higher the incision. That is the dictum. What we say very simply, lower the head because bladder is forward. If you go low down, you will be entering into vagina. Yes. So first thing is this, and the second thing,
higher incision. And when you are, as I think Dr. Ranjana already said about the delivery of that fetal presentation, if it is a deeply impacted head, it will depend that what presenting part is coming in your uterine incision. Like if I can feel both the shoulders, I am very happy doing a modified Patwardhan. Rather than pushing from below, I am not personally I am not in favor of that. I am more conversant and like more with the modified Patwardhan, when you can hook both the when you can hook both the shoulders and then the trunk and the legs and finally the head by the Burns-Marshall method. So, but some people definitely do go for that pushing method. Dr. Yash, your take on this?
But push technique is, as per literature, also less recommended than the other 2 options, like the reverse breech extraction and the Patwardhan.
Yes, Dr. Yash, your comment about it.
You have to be very Liker has already drained. She is a complete dry presenting part is out there. So extension of the uterine incision can occur to both the uterine arteries and even above. So you have to be and the all the tissues have become so friable that extension will be occurring if you're not very well with your, and do not panic. And that is the moment actually when the stability of the gynecologist is checked, when you are actually delivering such kind of babies out. And
I think what we say very, very nicely done by it, that Ashmana says that reverse internal podalic version fair and pushing is also considered good. But actually what I want to say, that even if it is a deeply impacted head, once you break the vacuum, you don't need actually anything. You push the hand, and once the break is the vacuum is break, it comes very easily because patient is in pain. So uterine contraction actually assists her. So many times it is the breaking of vacuum that is very, very
Actually,
important.
your extraction of the baby will depend what part is presenting.
What
part is presenting at the uterine incision.
And Patwardhan is a very good maneuver, but somehow, just like in a few days ago, we have the webinar and Dr. Tikisha says, you must be well versed about it.
0 to +1 is very easy to deliver. What you're talking 0 to +1 never trouble.
Yes,
What is only +2 and beyond. And I think pushing from below, if you're not confident, is not a bad option in many situations.
Yes.
That's a breech extraction is very easy in such situations, and a modified further if you're done. One very important precaution I must tell you: if you have decided for one, don't panic if it in first gets injured.
Yes, don't change your this thing. Yes,
don't change your maneuver once you have decided for one. Put your hand, it goes. And the thing is, tell your anesthetist to give a NTG patch or a nitroglycerin in the drip. The uterus relaxes a bit, and that moment of yours when the uterus is relaxing, these heads, they do not trouble. Pushing generally is required in +2 and beyond when the molding and those obstructed labor, fortunately, which we don't see anymore. But pushing, if you are not comfortable about doing Patwardhan, then please don't attempt Patwardhan. And if you have decided for Patwardhan, make sure you delivered by the baby by Patwardhan. Don't change midway. This is one common mistake.
Don't change your maneuvers. That is very important.
Very, very important message by Dr. Yash, because sometimes we do Patwardhan, when no, it is not working, then we again push the hand back into uterine cavity, and that makes a lot of extension into tears. So believe in one, but be ready, learn every technique, because we don't know and what we will be needing it. So because a lot of issue today is the technological world. So what we are achieving by the pushing our hand below the head, we have now the fetal pillow in which the air can be filled, or the normal saline, but nothing has been recommended for the routine use. So
I have seen many obstetricians, if the arm comes out, actually this is the situation that really tests your this thing. You have to reposit the arm. You have to make sure that it is a footling or a shoulder, whatever is coming. And once you decide for one maneuver, stick to that. We are not in a favor of doing this, that.
So we will be finishing in 5 to 7 minutes. Meena is waiting for us.
So the next thing here, so well that reflexes have seemed in so well that I think the operating the baby is the best person to decide what to do at that particular moment.
Yes, of course. So this is a key pool, rehearse every technique and know every technique. This is very, very important. Now you have delivered this baby and suddenly you find that this is very common, difficult delivery, second stage, and you are finding blood everywhere. So Dr. Sushmita, how you go for it? You are in the cesarean section, second stage of labor. A lot of blood filling up into your operating field.
So so you have to hurry a bit. You can exteriorize the uterus after placenta is removed, and then you nearly need to realize where your extension is. So you'll have to hold whatever edges you are seeing, and you should never hurry up, because if you are applying sutures blindly over here, you're bound to damage ureter at this time, which we are talking. That ureter at angle will be damaged. A ureteric injury will occur if we are just blindly taking sutures at the angle. So most important is to identify the edge if it is possible. If not possible, whatever edge you are seeing, you can just start suturing. And then definitely you can try for bilateral uterine artery ligation in such cases.
So thank you very much. You have summed up everything, because first of all, whenever there is difficult delivery, you have to be very careful that we have done anything injured, extension of incision, broad ligament hematoma, bladder injury as well. So you have to be very, very careful. So this is very important paper. What our seniors were saying, that juniors having unsupervised cesarean section, it is a UK study which says that the most of resident doctors are not confident of dealing with second stage cesarean section. So here is the way that we have to retain the old teaching ways, when the hand holding of juniors and building them confidence and teaching them right thing is very, very important, because this obstetrical training is not only issue of us, it is issue all over. And actually we don't want 7 hours second stage in the peeping into the labor. So this is very, very important. I think we will be not anterior placenta previa will be taken up one important question that is life threatening. You find unidentified possible placenta perfida on the table. So Ashmina, what you do say, you are in a not in an institution, you are having your own nursing home or hospital. What you do? We will take 1 or 2 questions and then we will wind up.
Yes, ma'am. One thing is that this should not come and unanticipated. We should be having a proper history. We should be suspecting an accreta if she was a previous surgery, if she was a placenta previa. So ideally, antenatal ultrasound must be diagnosing accretas. They have a good sensitivity, specificity, especially with a history of prior uterine surgery, maybe a cesarean, a myomectomy.
We must have the suspicion. And the second thing, the ultrasound, still is a wide level of expertise of ultrasound. So still it is around 90-95%. So we can have. So one message which we want to give, whenever there is a clinical spectrum of possibility of placenta perfida, you base on that also, that this patient I might be dealing with the placenta perfida. So Ashwina, what you do when you are all alone in your small nursing? Very common situation.
If you are still stuck up with the situation where you were doing an elective surgery and you have got stuck up with you opened the abdomen and you realized it is percreta, and you are alone in a small setup, please do not give the uterine incision, provided the fetal status was reassuring once you had opened. Stop there only. There can be 2 kinds of situation. One, you can arrange everything at your very place. Second, you cannot arrange. So if you can arrange, very good, but please wait till the help arrives, till everything is arranged. Call for help, not only from the obstetric point of view, also from the anesthesia point of view, from the blood and blood products point of view, from the urologist point of view, depending on how bad the situation is. And secondly, if you cannot arrange at your place where you are, and the fetal status was okay once you had when you had started, please close the abdomen and send her at a place where everything can be arranged. Once you have given the uterine incision, then you have put her and yourself into a suit. So that will be life.
Thank you very much. This is a very, very clear message from Ashmina. First you say identify 1, 2, 3. कभी-कभी एकदम clear नहीं होता placenta perfida, but you are pursuing distended lower uterine segment, a lot of vessel. Stop it and see stepwise. Just like never and never give oxytocin or carbitocin in those patients, because once it is started contracting. So this is very important. Either you call your friends, blood component anesthetist to your place, collect everybody, or you refer the place where all people are available and all. So this is something a life-saving decision for the obstetrician as well. So we will take finally this thing. I am not going to it. One last we will take after meeting, that you find a myoma during cesarean section. One situation it is outside your line of incision, and one situation is that you are having the right at the proposed site of uterine incision. So Dr. Yashwala, your comment about this is also our day-to-day issues now.
If the patient is well preserved and the hemoglobin and everything is okay, the one in the incision, there's no confusion. I'll remove it at the time when I remove the baby. Even the one which is the fundus, I mean, the time is when you used to say that you should not touch the fiber, the time of cesarean is no longer there. If I feel the patient has a normal hematocrit, the other parameters are okay, and confident, I don't mind removing even the fundal fiber with a sizable size to avoid a surgery at a later stage. So the one in the incision has to be removed. The one otherwise also attempt, I will remove when I'm confident. Those who are not should not attempt it. But I think when you are prepared for it, with a written informed consent, you should remove the fibroid if you feel that things are okay. I think before I cut short my one very important carry-home message that I should not forget: whenever you are doing a cesarean section for a patient with a previous cesarean section or a low-lying placenta or fibroid, please take a written informed consent for a peripartum hysterectomy before you wheel in the patient to the theatre, rather than ending up in taking that consent for hysterectomy intraoperatively which may not save you post-op or a legal complication. Any high-risk cesarean, take a consent for peripartum hysterectomy, please.
So I think we have a wonderful discussion. Actually, I am awed with the expertise and experience of everyone. We have a lot of cases, but I think we cannot do in the one panel and we will not go for the thing. So finally, no matter whatever expertise you have, we are sometimes falter and be compassionate and be sympathetic to your mistake and to the others. This is not mistake, it is part and parcel of surgery. So what is reasonable to us, that we never cease to aim for perfection. So thank you very much for active discussion. No pressure, no diamonds, that is it. Now, we could not take the other cases, but we will be together because of a wonderful expertise from all the panel and our experts. So finally, thank you very much for the active discussion.
Thank you.
So
Thank you, ma'am.
Thank you all the panelists and the experts.
Votes are
Great
all yours.
discussion.
Excellent, Dr. Sadhana, for a wonderful session. I think enjoyed every minute of it. Thanks all.
Thank you, ma'am. Thank you, madam. Your words matter a lot, and it was all expertise, all very, very clear input, and I think we have learned a lot. Dr. Vineet, yes.
Thank you so much.
Thank you, esteemed faculty
All of
members.
them to vote. Dr. Yash?
We have one lecture.
We have one more talk.
We have one more talk for Piyush. Yes, Vineet. डॉक्टर विनीत आप कुछ कह रहे थे?
नहीं, मैं ये कहती हूँ कि पंजाब के सारे वोट्स आपके हैं. We will make sure that you win.
Yeah.
Okay,
Same from
thank you
here.
so much.
Ma'am, I'll have to
All the
leave.
votes from our society also.
Ma'am, Dr. Sadhana, I have to leave. Can I? Thank you so much.
Yes. Please.
Thank you so much, ma'am. That was really wonderful.
Thank you very much for this. So we have the Meena, who will be taking with the journey of the postpartum care. So Meena, thank you very much for waiting with us and bearing our a little delay. So Ritu, you go on with that.
Move on to the talk, and the talk will be taken up by Dr. Meena Samant. The topic is post-cesarean care and complications. I invite the chairpersons for this talk, Dr. Umesh Jindal and Dr. Rini Brar. Dr. Umesh Jindal is the consultant IVF specialist and at Jindal IVF Center and Sant Memorial Nursing Home, Chandigarh. She's a pioneer in IVF and infertility management, Vice President of Indian Fertility Society. She has been in the year 2016 and 2018. And she was instrumental in starting the IFS Art Diploma course in 2014. Section Editor, Clinical Art Journal, Fertility Science and Research. Her center has been judged as the best IVF center of Northern Region by ET Health World, Madhurima Editors, Choice Bhaskar, Women of the Year Award 2011. Icon of the Year IVF North National Fertility Awards 2019 Economic Times. She has more than 35 national and 15 international publications, and she has written chapters in 10 books. So welcome, ma'am. We are honored to have you on this platform. Our second chairperson is also a very brilliant and she has been brilliant right from her school days. She has been a topper everywhere and won medals and gold medals, so many merits and honors she has. And she's also the winner of Best National and International Presentation more than 3 times. And her national rank in senior resident exam was also first. So welcome, Dr. Rini, a brilliant performer. Welcome to this platform. So over to Dr. Rini for introduction of the speaker, Dr. Meena Samant.
Thank you so much, ma'am, for the very kind introduction. I would like to welcome Dr. Meena Samant for our last talk today. Ma'am is Senior Consultant and Head of the Department at Department of Obs and Gyne at Kurji Holy Family Hospital, Patna, Bihar. She's been the chairperson of FOGSI Clinical Research Committee in 2019 to 21. Ma'am has been General Secretary of ISOPAB. She has been Vice President of the Patna OBGY Society. She has been Secretary of Patna OBGY Society. She had held the Kamini Rao oration in 2005. She has been the organizing secretary for Yoga FOGSI in 2011 and for FOGSCON in
Dr.
2000.
Rini, thank you. I think it's an old one that I have
Welcome.
by mistake sent it here.
Welcome, ma'am.
Welcome, ma'am.
Okay. Can I share my screen?
Yes, ma'am.
So I've been listening to all the talks and really enjoying what wonderful.
Piyush, stop sharing your screen. Piyushji. Yes, Meena, ma'am. Yeah.
Is it visible now?
Yes, ma'am. Yes, ma'am. Make it full screen. Click on the wine glass.
So, yet cesarean is just not yet another way to get out. We know, like every patient is a different one. The situations are different. The surgery may be a little more different from the other. And likewise, the post-operative care has also to be tailored. So, important features in the care of a woman following delivery by cesarean section is we have to monitor the mother for all the vitals. Then we have to look about the prophylaxis against hemorrhage because bleeding is very much more common after a cesarean delivery. Skin to skin contact of the baby, that's not to be forgotten. Pain management, thromboprophylaxis, early ambulation, bladder catheterization and care, early food intake, breastfeeding, care, and contraception counseling, all this and more. But of course, I'm going to limit myself to some important aspects. One is, of course, maternal monitoring. Following cesarean section, the woman should be initially observed in the recovery area. One-to-one observations should continue until woman has airway control, cardiorespiratory, and can communicate. Well, this is not much of a problem these days because most of the cesareans that we do are under spinal or epidural. The observations that have to be included are pulse rate, blood pressure, respiratory rate, temperature, oxygen saturation, urine output, and the charting. Half-hourly observation should be performed for hours, then hourly the woman is stable, and we have to look at the vagina. This by shortcut I've taken from somewhere. The early warning criteria: systolic BP less than 90 or more than 160, diastolic more than 100, heart rate less than 50 or more than 120. Even I would say more than 100 if the baseline has been something like 70 and 80. Respiratory rate less than 10 or more than 20. Oxygen saturation on room air at sea level less than, if it is less than 95, oliguria, we all know that. Maternal agitation, confusion, or unresponsiveness. Patient with preeclampsia reporting a non-remitting headache or shortness of breath. All these we have to look for and actually record. As we understand that bleeding is more common after a cesarean delivery, IV oxytocin infusion as prophylaxis against postpartum hemorrhage, especially if there are risk factors for postpartum hemorrhage like the prolonged labor, macrosomia, multiple pregnancy, and these days, I think many of us have shifted to carbetocin. Here, of course, we would not be looking at oxytocin drip. Now, administration of 1 gram tranexamic acid, if it's been given before, yes, that can also help as a prophylaxis. Then skin to skin contact with the breastfeeding, with the baby, it should begin soon after birth, and it can start in the OT itself. And even the breastfeeding should be started as soon as possible. The OT maybe, but definitely within an hour of delivery. The pain management is so important. Goal is to allow maternal neonatal bonding, facilitate mobilization of the patient, and acetaminophen and NSAIDs, can be administered round the clock. Those who are on epidural, of course, stopping would be needed. Then, in addition to the pharmacotherapy, placing an abdominal binder at the end of the surgery during the recovery can improve patient's discomfort and the mobility as well. Opioids may be given, they can be avoided rather if we want bowel mobility to come soon. Then thromboprophylaxis we should not forget, because not all of us, routinely think about it. So pneumatic compression device can be placed after cesarean section. Early ambulation is encouraged, maybe as soon as 6 to 8 hours, and hydration should be maintained. In high-risk pregnancies, heparin can be started 8 to 12 hours post-operatively, and in those whom it's being started can be continued for 7 to 10 days. While in high-risk, significantly high-risk patients, like the previous history of VT, thrombophilia, and so on, it can be given up to 3 weeks or even more. Yes. Early ambulation is always encouraged. Ambulate for at least 5 to 10 minutes 4 times a day, and it can be started as early as 6 hours. It helps in decreasing the risk of pulmonary embolism, easier physical recovery, and higher mental satisfaction. So, bladder catheterization is done during cesarean, but it can be removed as soon as practical, maybe even after the skin closure, because it minimizes the risk of infection. However, looking at the logistics and the practicality, maybe we may have to continue longer, but sooner we remove it, lesser the rate of cesarean death of UTI. Again, early food intake is something we encourage. Maybe as soon as 2 hours, we start with clearly liquids. And early intake may enhance return of bowel function by stimulating the gastrocolic reflex. And chewing gum, by some authors have said the phantom chewing, eating that encourages again the gastrointestinal. Coming to the wound care. For a clean surgical wound, epithelialization typically occurs in 48 hours after surgery. The superficial layer creates a barrier to bacterial and other infectious organisms, and data from RCT suggests that removal of this after 48 hours have no detrimental effect on the outcomes, and adhesive dressing should be removed slowly in the direction along the hair growth and at an angle of 152 degrees, pain, pulling, and pulling of the skin. There is no conclusive evidence of harm from post-operative showering within 48 hours of surgery in patients with closed surgical wounds, and non-absorbable sutures, if used, should be removed at 7th post-op day till the wound is able to hold itself, and if staples are used, it can be removed in 4 to 6 days and can be delayed up to 10 days if the patient. But I think most of us these days are going for absorbable subcutaneous sutures. Now that was briefly about the routine care, but tackling the complications. Now there can be a huge lot of complications in the post-op period, and I will just cover some of them. One, of course, is, like I said, the postpartum hemorrhage, paralytic ileus, hematoma of the abdominal wound, infections, the post-dural puncture, headache, pulmonary embolism, and psychological conditions. So there was this 27-year-old para-1 living one woman with the first post-op day of emergency cesarean delivery for the second stage arrest, has a pulse of 110 beats per minute, BP 80/50, respiratory rate of 20 per minute. On the per-abdominal examination, the uterus seems to be contracted, but is lifted above the umbilicus, looks quite huge. There is only a mild soakage on the pad, but on pushing, massaging the uterus and doing a BV, we find huge amount of collected blood in the vagina and the lower uterine cavity. So this patient responded to oxytocin drip, IV methyl albumin, tranexamic acid, crystalloids, blood. So here the learning point was the blood loss may not always be revealed. We have to look for it, and the signs are pointing towards some kind of a loss, and we have to be mindful. Again, secondary hemorrhage is something that occurs after 24 hours or more following. And the usual causes described are the endometritis, retained products of conception, subinvolution of placental site, implantation site, and maybe some mucous fibroids, which is delaying evolution. It is often preceded by advanced warning signs in the form of increased red luteal discharge. So a huge amount of bleeding, not there, but trickle, red fresh trickle can, give us pointers. So management would include assessment of the hemodynamic status and the blood loss, endocervical swabs, CBC, ultrasound to assess for the cause and manage it. In the post-operative period, paralytic ileus can be quite common, and the incidence has been described as high as 10 to 15%. Constipation and intolerance to oral intake due to non-mechanical causes after surgery. Nausea, vomiting, absence of status, pain and distension, worsening from the time of cesarean section. This is the usual presentation, and the treatment would include IV fluids and electrolyte replacement, antiemetics and nil orally. Nasogastric tube, opiates, analgesics should be avoided because it may hamper with the motility of the.
Ma'am, we can't hear you.
Trying to. So, post-operative pseudo-obstruction is something less common. But now with the rising rate of cesarean deliveries, this is another complication we can see more of. Mrs. S. Primey, 32 years, conceived after treatment, had cesarean delivery at 39 weeks for a breech presentation and a huge fibroid. The fibroid was 10 into 12 inches in size, right anterolateral wall of the uterus. There was mild PPH, mild to moderate PPH during the cesarean delivery, and which was managed by oxytocin. On the day to see, she started having distension and pain in the abdomen, which is mostly localized towards the right side. Of course, various DDs were kept in the mind. CBC, electrolytes, X-ray abdomen, and ultrasound all were done. There was colonic dilatation seen. Ultrasound showed mild ascites, minimal and dilatation of the bowel. So what basically is Ogilvy syndrome? It's a disease progressing with acute dilatation of colon without a mechanical cause. During cesarean, Ogilvy syndrome may be caused by damage to the parasympathetic nerve supply that runs close to the cervix, vagina, and broad ligament. The colonic distension may lead to perforation of the cecum, especially if the cecal diameter exceeds 12 centimeters. Mortality rate for pseudo-obstruction is 50% if the patient progresses to ischemic necrosis and perforation. So these are some photographs taken from the net. This is the X-ray picture showing the colonic dilatation, and the same with CT scan. The initial treatment includes hydration, rectal nasogastric tube placement, correction of the electrolyte imbalances, and discontinuation of medicines that hinder bowel motility, decompression via the colonoscope. IV neostigmine may result in resolution of the pseudo-obstruction within 10 to 30 minutes. A 2.5 milligram dose of neostigmine is slowly infused over 3 minutes under close cardiac monitoring. If cardiac atropine should be administered. Laparotomy with osteotomy, radiation, and bowel section for peritonitis and ischemia is the last resort. Coming back to the case that I just alluded to, IV fluids, antibiotics, Ryle tube, latest tube, enema were all given. After some initial improvement, there was sudden deterioration with a pulse rate of 40 minutes per minute, heart rate of 140 beats per minute, BP systolic 80, severe distension and pain. Peritoneal tap showed fecal matter. Urgent laparotomy was done. Of course, this is a team effort, and surgeons were in the forefront. Cecal perforation was close, and side-to-side iliotransverse anastomosis was done. Myomectomy followed by hysterectomy. I will not go into the details of hysterectomy. Yeah, there was a concern that it may, disrupt the healing of the repair. The patient was in a ventilator. The hospital stay was 1 month and patient survived. So these are some of the pictures. Now, septic shock. This is another dreaded infection and it may occur after. There are certain high risk factors. I would like to present this case of Mrs. S, 30 years, brought to our casualty department. She had a cesarean section done 15 hours back in a private establishment, which was a standalone this thing. Why they took this case in their place? It was an IVF conception triplet with one fetus having died in utero at 28 weeks. And the cause probably was patient was in severe distress. Probably she had some element of infection even then. She had received 1 unit of blood before she was transferred to our center. Pulse rate was 120, BP was not recordable, respiratory 30, SpO2 95 on oxygen mask, and temperature was 101 degrees Fahrenheit. Mentation, she looked drowsy, she was talking, and she responded to verbal and tactile stimulation. So these were the investigation. WBC 32,000, bilirubin was high, PT-INR were raised, serum creatinine. So it was already a multi-system involvement, and when she was in acidosis, normal cardiac function, the echo showed collapsed IVC. So not only was she in acidosis, septicemia, she was also in a state of. So of course, coming back to the status, person suspected of being in sepsis, one has to be really very prompt in the management. Administer the rapid initiation of multiple overlapping actions, administration of 100% oxygen by rebreathing mask, obtain blood cultures, broad spectrum antibiotics to be started within an hour, serum lactate at more than equal to 4. And we have to start off with crystalloids even before that, and we have to maintain a vasopressor, MAP of more than equal to 65. CV should be more than 8 millimeters of mercury, and we have to be mindful. So, if infection, they do keep occurring off and on, especially in emergency cesarean and high-risk patients, obese patients. This is V, 34 years, G2, P1, L1 with previous cesarean with gestational diabetes. Cesarean section was performed. On day 1, incision side pain, there was mild redness, infraumbilical area tenderness was there. There was no discharge. Day 5, there was fever, redness, swelling, increased leukocyte count was high, and there was falling. SG showed small collection in the parietes, which was evident. Now, incidence of wound infection following cesarean section can be 1 to 4.5% depending on the patient and other factors. Patient may complain of pain at incision site. There may be local redness and discharge from the site. With most serious infections, the stitch may be given, and type 1 necrotizing fasciitis results from polymicrobial infections, polymerobic and anaerobic, while the type 2 is generally caused by a single organ, that is GBS. There could be some predisposing factors like the prolonged labor, prolonged rupture of membrane, prolonged surgical time, poor tissue management, contaminated instruments, nutritional status, diabetes, anemia, and many. Then management for the treatment of clinically apparent infection, a blind treatment with 5 to 7 days course of cephalosporin or metronidazole or augmentin are reasonable first-line therapies. Daily dressing, debridement, resuturing as the case may demand. There's something called, I think many, but this was new to me, vacuum-assisted closure. Negative pressure wound therapy or VAC, that is vacuum-assisted closure. It's a popular treatment modality for the management of acute, unhealthy, or chronic. It accelerates wound healing by decreased tissue edema, excessive exudates, and infection. Appropriate wound debridement is necessary before application of VAC. Dressing and tubing are typically changed 48 to 96 hours depending on the clinical situation. Contraindication in wound with exposed vital organs, presence of malignant tissue ischemia. In this patient, this was done and resuturing followed after the wound became healthy. and 3 changes of this instrument. So Mrs. A had an emergency cesarean section for the second stage arrest. There was an extension of the uterine incision at the right angle down towards the lower uterine segment, which was secured. During post-op period, she presented with abdominal flank pain, fever, hematuria, and weak urinary stream. One has no ureteric injury in cesarean section is pretty uncommon, but then there can be some instances where it occur. Clinical features to look for would be fever, pain, abdominal distension, sepsis, peritonitis, ileus, retroperitoneal urinoma, urinary leakage from the vagina, drain site, and abdomen. And investigations to make the diagnosis would be increased serum creatinine, renal USG, IVP-CT with contrast, cystoscopy with retrograde urinogram. And management, of course, we know the site is most commonly at the junction of ureter and uterine vessels caused by ligatures and angulations. It could be partial or complete. An intervention of urologist is needed. If they are just the partial transection, stents can be helpful. Complete transection, new retrocystoscopy or uretero. So that depends on what it is, and it may be sooner or later depending on the presentation and when it is diagnosed. Now, peripartum cardiomyopathy is something we are encountering more. Maybe because more IVF, planning late pregnancy, your body, age. Though age is no onset of heart failure in the last month of pregnancy or in the first 5 months of postpartum. Absence of determinable cause of cardiac failure and absence of demonstrable heart disease before the last month of pregnancy, and echocardiogram evidence of new left ventricular systolic dysfunction, and that occurs in postpartum. So, patient has delivered, she is in the recovery, and suddenly she starts having dyspnea, dizziness, chest pain, fatigue, palpitation. There may be peripheral symptoms, and the BP may be normal or tachycardias. There may be crepitations, hepatomegaly, symbolic events, JVP distension, gallop pregnancy. Like I just mentioned, all these risk factors. That's why we encounter them. We have to. You have to rule out others like the pulmonary edema, heart failure, myocardial infarction, pneumonia, amniotic fluid embolism, pulmonary thrombosis, and sepsis. So diagnosis is by echocardiography, and of course all those features. On the left, ejection ventricular fraction less than 45%, fractional shortening less than 30, left ventricular and diastolic pressure more than 27 centimeters per meter square. Heart is enlarged with global dilatation of all 4 chambers and marked repeats left. These pictures again are taken from the net, and as you can see, it's a 30-year-old patient, while this is a 22-year-old patient presenting such conditions. So management would include thromboprophylaxis, treatment of heart failure. Bromocriptine may help in remodulation of the heart muscles. Sometimes even cardiac transplantation may be required. Maternal mortality can be high, but there 50% have full. Now, headaches can be quite common as we take our rounds in the stop report. Mrs. A had a cesarean 2 days back for fetal distress. She was doing well. Afebrile, eating, voiding. Since last evening, she had severe headache, and now she's having headache and vomiting, unable even to breastfeed. So differential diagnosis can be preeclampsia, post-dural puncture headache, cavernous sinus thrombosis, paranoid hemorrhage, benign intrauterine hypertension, migraine. I've left out other infections. Post-dural puncture headache, and now because many spinals are going on, they use the tiniest of the needles. So it does occur often. Caused by puncture of durameter during spinal anesthesia, involves back and front of head, spreads to the neck and shoulders, exaggerated by movement and sitting or standing, relieved on lying down There may be nausea, vomiting, tinnitus, vertigo. And of course, treatment would be patient lying down, hydration, paracetamol, NSAIDs, opioids, analgesics. Caffeine helps epidural blood patch. Even, tying an abdominal binder. Pulmonary embolism, Mrs. SP, 31 years old, irregular antenatal care in periphery, came to the hospital and transfers fly, emergency cesarean done. BMI of 30, POD1, she complained of sudden onset shortness of breath, chest pain, palpitation, reduced oxygen saturation. Patient was shifted to ICU. Her pulse rate was 120, respiratory rate 28, BP 80/60, SpO 76. And the lab test is Awaz Mat Kijiye. Lab test revealed hemoglobin of 12.3, platelets 170. So D dimers were raised, troponin T was mildly elevated, arterial blood analysis on 5 liters, oxygen showed respiratory alkalosis, and the oxygen saturation up to 98%. ECG showed S1Q3T3 pattern, which is not a very common, classically described, not very found. Doppler ultrasound of the lower limb was excluded. DVT, excluded DVT, found more in favor of pulmonary. She was given heparin, enoxaparin, and gradually, and of course, antibiotics and all that, and gradually she improved. But she was sent home with enoxaparin, which was to be continued for 6 months. So pregnancy and puerperium, are well-defined risk factors for DVT and pulmonary embolism, collectively referred to as venous thromboembolic disease. This can present in puerperium due to immobility and the procoagulant stage of pregnancy. Diagnosis based on clinical and lab parameters like D-dimer, ECG, echo, chest X-ray. Management can be individualized, ranging from anticoagulants to thrombolysis to thrombectomy. Early mobilization, ambulation, pneumatic compression devices, prophylactic heparin can be beneficial in the postpartum, and we should, I think, make it a habit to actually risk for our patients that proper prophylaxis can be taken. And when symptoms arise, very alert to it. We should not forget the psychological conditions. Mental disorders can precipitate this period. Cesarean birth has been associated with increased risk of postpartum depression. Some patients express strong feeling of loss, failure, and after a cesarean. These feelings are likely related to anxiety associated with medical and obstetric conditions, the stress, the pain, the fatigue associated with surgeries. Better psychological outcome may be realized with realistic preparation for childbirth, maternal involvement in decision making, and analyzing patients' baseline psychological status. So, looking for anxiety, all those things in the family history and patient's past history can be very beneficial. So these are the 3 commonly found postpartum clues, which set stays for 2 to 3 days, resolves up to 10 days time. But this is a milder form. Postpartum depression, patient is anxious, depressed, poor concentration, usually starts within the 3 weeks, and there can be lots of harming the self and the baby. The cognitive behavior therapy in SSRIs can help. Psychosis is more dangerous with delusions and hallucinations. Fortunately, the incidence is much less, 0.1 to 0.2%. Thoughts of harming the baby or self present, hospitalization, and electroconvulsive therapy. So I would like to conclude my talk by saying we have to, in the course of baby, we have to prioritize rest, pain management, care. Baby and breastfeeding should never be forgotten. Early ambulation and principles of enhanced recovery. Vigilant post-CS monitoring, the news chart, lend ear to the patient's complaint, and there should be clear communication. We have to be very patient about listening to the patients, because that can give a lot of hints to us what may be brewing. Involve multidisciplinary team. Thank you very much for the patience listening.
Thank you so much, ma'am. Thank you for such a wonderful talk. And you have covered almost everything. So over to Dr. Jindal for the concluding remarks.
First thing I want to congratulate Dr. Meena. She's covered so many subjects which are full talks in themselves that in this time. And second thing, I would like to ask permission from Dr. Sadhana because we are already 7 p.m. So should we devote some time for discussion or?
Yes, madam, we can take 5 minutes. It's okay.
5 minutes. Okay, thank you. So
5 minutes. Yes,
I think you have covered the complications very well. So we'll not go into the details because again, that would be an endless discussion. We will concentrate on few important points in routine care, which is supposed to be there. So my question, see, you make some points. So I would like to ask again. Whether, I mean, this is, and ask other experts also, what is their practice? Number one is regarding tranexamic acid, because these are the things which confuse everybody, whether to use or not to use. I mean, routinely, if you have bleeding, then most of the people would give, but routinely, do you give?
Yes,
Meena, first you,
yes.
Meena, first you say. Meena, what's your take on it?
1 gram prior to surgery. 1 gram prior to surgery, just on the table, we give it as a routine.
Is there any recommendation for this?
Yeah, I think we have reduced, I think in cesarean section, there's hardly 50 cc's loss. At times I feel surprised, how come? There's hardly any blood loss. Kindly do it. It's really good.
Yes, madam. Actually, it is any patient who is having high risk for hemorrhage. Maybe she is on the drug, maybe other factor, then like it is recommendation we can give. In setting of PPH, of course, it is to be given, but for all cesarean section, it is still plus minus. It depends upon practice, but every patient who have high risk for hemorrhage or otherwise a normal, like a extra risk for bleeding, the tranexamic acid is a good choice. And always in setting of PPH, always it is one of the things. Rini, your comment. Rini wants to say, I think.
And my second question is regarding oxytocin versus carbitocin.
Rini, first you say you want to say something about tranexamic acid.
Both these things, ma'am, about the uterotonics, a lot of clarity has been given in the newer guidelines now, which say that for cesarean sections, if it is an uneventful, uncomplicated cesarean, simply oxytocin would suffice. But if there is any cesarean which is a high-risk cesarean, then we have to give mithergin along with oxytocin. And if we have high risk of bleeding, such as previous history of PPH or any preeclampsia, multiple gestations, polyhydramnios, any such high risks of atonic uterus, then we have to give mithergin along with oxytocin. This is what the new guidelines say. About Tranexa, just the woman trial is there, which says that the incidence of PPH is reduced, just like in traumatic patients, but it has not found itself in the guidelines yet. In treatment, definitely, yes, it is a part of the guidelines.
And what about carbitocin?
Carbitocin, ma'am, is used just in Canada as a therapeutic, as a prophylactic measure, but everywhere else around the world, it is not yet being used. It is just used as for prophylaxis in Canada.
So I think we
like
cannot
No,
pass.
I will really I'd like to differ a little bit because active management of third stage labor, which is like now I have spent years in FOGSI. So what do you say, madam? Actually, what is the carbitocin is a paradigm shift. And our country is actually very lucky. We are having a very, very good availability of carbitocin because in many countries, it is government funded. So even in a developed country, it is not that freely available. Carbitocin, why it is so very important? First of all, universal active management of third stage of labor for every woman. So it is a oxytocin 10 unit intramuscular or in the fluid or the misoprostol as a second choice was the thing what we were practicing. Now we have the carbitocin. The beauty of carbitocin is that it has a very, very strong acting affinity on the oxytocin receptor. It is long acting. And third is we have the room stable carbitocin as well. So in our country, when you have a lot of issue in the cold chain and lot of issue in the summers, we are always having 38, 39, 40 degree temperature. So carbitocin is a real boon and armamentarium to all of us. And carbitocin as a active management of third stage of labor, replacing oxytocin has been recommended by many organizations. And FIGO also says even in vaginal delivery, it is a good choice. Just you have to consider the cost constraint. So in private setting all over the world, the private people have used initially, they have started and they are preferring. And in government setup now, it is going to be available because the government is negotiating. They are giving at a lower price. So carbitocin is a something, and especially in anemia, preeclampsia, when we don't want any like a continued oxytocin, continued IV fluid, a single dose of carbitocin is very good. So it is a drug. It is a treat to see. You give carbitocin and you see placenta delivering, which was not when we were using oxytocin actually. So developed world is sometimes lagging. So many issues are there, Dr. Umesh, that the developed world is lagging from us. Be it a MTP laws, so many things are there that we are far ahead of them. Amina, your comment about it. Because your experience in your unmute yourself. Unmute.
Yeah, we actually, when we started using carbitocin for cesarean section, was as a part of a thesis that we'd given to us. But the results were, actually, we were very happy with the results. And now that we have also started giving selectively for the vaginal deliveries. I mean, I think the results are pretty good. And after vaginal delivery, they can handle their baby. They don't have to be with the IV drip along and all that. So, but then of course, any drug is not a panacea for everything. We started it as maybe a trial or thesis topic, but it's good. I would say it's good. And now we have for cesareans practically 100% to carbitocin. But we have to remember if there is PPH, she is being given carbitocin for 3 hours. Probably the oxytocin centrosome drip would not act because the receptors are blocked. For that time, you have to give methogen and other oxytocins.
Okay. Now, the other question is regarding early ambulation, about after 6 hours, because till now, most of the cesareans are done under spinal and
earlier. I mean, it's very patient dependent. Some patient, after some time, you don't even recognize that they've just recently undergone a cesarean or a delivery. They are with their own suits and sitting at the chair by the side.
It's again a real shift to instruct your nurses, to instruct your patient, to start mobilizing after 6 hours and give them food after 2 hours. This is
2 hours, I would say, is too early. But 4, 5, 6 hours, yes, we start with clear fluids in our hospital as well. But remember in Delhi, where my sister had a cesarean, after 4 hours, she was sipping this mango juice. Fruity. So, going through the eras, though, if it's
fruity, I will just like to say fruity is not good for anybody because it is acidic and lot of sugar, and it is, I think it is a black tea is good, green tea is good,
green tea or lemon tea, I would prefer.
But fruity is not something. Yes, madam, yes.
I think for the last so many years, it's totally epidural. And my patients, they get up and walk around after because it's a walking anesthesia as soon as they can walk. So I encourage their mobility very soon and they can take fluid within 2 to 4 hours. So that is the added advantage. So as far as carbitocin is concerned, for the last 9 months, I've not used the rest of the things, no methogen, no pitocin, no. So we switch on to even for the normal deliveries and say, since I'm in the practice, so I've got the choose and I see tremendous, benefit of that. Thank you very much.
I just wanted to emphasize these points. And one important point in post cesarean care is the care of medical complications which were there during pregnancy, like thyroid, diabetes, preeclampsia, all those things need management postpartum also, and there are specific guidelines for each of these problems, and these should be followed, and all these patients are high risk to continue these diseases after delivery, so they should also be followed up after 3 months or something. So the specific guidelines are there for every condition. And the last but not the least, we all forget to talk about contraception. That should not be there. Although I'm an infertility specialist, but contraception remains one of the priorities after any delivery.
Okay, thank you. Good.
And
Thank you for taking up very, very valid and pertinent point. Thank you, Dr. Umesh. Rini, you want to say, no? You wanted to say.
Interestingly, we have had a thesis at PGI where we removed the catheters just 2 hours after cesarean and encouraged the patients to pass urine as soon as they could walk. I mean, immediately 2 hours is after the patients were shifted, almost immediately after the cesarean removed the catheters. And the success and the patient satisfaction scores were equal in those who had catheterization for about roughly say 12 hours, which was the routine protocol, compared to early removal of the catheter. The rates of satisfaction were similar.
Actually, we remove catheter after 24 hours, I mean, next day morning, and we have no problems. I mean, our COTI rates, it's monitored under NABH, it's practically zero. So even say they are so comfortable, but if you want to encourage ambulation, then you can take out catheter early. That's what I would say.
Thank you, ma'am. Thank you for the great inputs. Thank you, Dr. Meena. Thank you, Dr. Umesh. Madam Jindal. Thank you, Rini.
Part of this marvelous discussion. Thank you so much.
Thank you, Meena, for your precious time. Thank
All
you.
the best, ma'am.
Thank you.
And over to Ritu for the vote of thanks. Ritu.
Thank you. Thank you, ma'am. It's my proud privilege to propose a vote of thanks on this occasion. My heart fills with gratitude and respect for our revered guests, Dr. Sharda Jain and Dr. Sushma Chawla, for enlightening us with their inspirational words. I'm extremely thankful to the speakers for their commendable talks on the subjects. And a big thanks to the chairpersons for their very, very valuable inputs. I'm really very thankful to Dr. Sadhana Gupta and Dr. Amrita ma'am for their best effort and guidance. I thank the panelists for their brilliant discussion and brilliant inputs. And in the end, I would give a big thank you to the organizers for making this webinar successful. And namaskar to all of you.
And thank you, Corona, for like all very.
Thank you.
And thank you again, once again, Patiala and North India Society. And Rini, you were our young upcoming star. Rini, you are there or not?
Yes, ma'am.
She is there.
So we will be
joining NHS.
Thank you so much for calling me in, ma'am. It was an absolute delight to be here and listen to all the great, all big gynacs. It was my pleasure entirely. Thank you so much.
Dr. Reddy, you are joining NHS. I had heard about it.
Yes, ma'am. I am in London right now. That's why the sweating and
I see. Wonderful having you here.
And Madam Sushma Chawla, gratitude for your staying till the end. You are listening, and that is a great motivating for all of us. Unmute, Madam. So, Dr. Umesh, thank you. Your presence always enlightens. You are like taking up discussion, and that makes the all purpose very, very worthwhile. Thank you, Dr. Ranjana. Thank you. So thank you, Piyush.
Thank you, madam. We had a very good discussion on carbetocin. So I just want to take only 2 minutes. We have just introduced DrSadhanaGupta RTS. So this was not planned, but because we had a discussion, so I just want to say that we have introduced this. That is a room temperature stable as discussed. It will be very helpful for all the patients who go into the cesarean as discussed. Thank you very much.
Good. Congratulations, Corona, for it.
Yeah.
I really endorse it.
Thank you.
Thank you.
So, good evening, good night, we can say.
Yeah, thank you all esteemed faculty members. We are looking forward to connect with subject experts like you to organize many such programs in coming days. On behalf of Team Corona, I would thank you all for sparing your valuable time. Actually, Mr. Piyush was going to take this session, but he was not able to come. So I am Ruchir Gandhi.
So we were calling you
I
Piyush
was
all the time.
conducting this. No issue. It is not your fault. It is I was not able to introduce myself earlier. So
anyway,
thank
we
you
were
very
addressing
much.
you only. We were addressing you only.
Yeah, I understood. I understood. No issues, madam. Thank you. It was very nice interaction, and hope we will
be needing recording of this session. So you send me recording.
it is available. It will be available in YouTube. I will send the link.
You please send so that we can share. Thank you.
Oh,
so we can say good evening, good night.
Yeah.
Good night.
So long.
Good night.
Good
Next
night.
week. Yeah.
Okay, bye-bye.
Bye bye.